really the key to try to support the state and local health departments and all of the practitioners in the community who are really the front end providers for tobacco counseling, connections to the quit line, and to education. And we do provide technical assistance to everyone. So if you think of something you need to in this framework, please do give us a call. We'll try it again. Yes, works. So this is our last Tobacco Control Center Best Practices Conference, which we had in the spring. And you can see it was very well attended. Those were some of the people down here who put it together. And again, very thankful for my wonderful team that is really absolutely tirelessly working all the time. This is the reason we exist. Okay, we exist because of all these people who are vaping, smoking, hookah, chewing, and the newer nicotine pouches that are out there. And when they go into the gas stations or any of these convenience stores, that's what they see. There's just hundreds of these products right in your face. They're lovely colors, shapes. They look beautiful. They make you look cool. So that's why we exist. Other things you want to keep in mind is Black and Miles. I always think I'm going to say that, but now I have a slide to remind me to say Black and Miles in Baltimore. That is what children have been using, including little blunts and little discarded stump, the end of the cigarettes. They pick up these filters, they attach paper. So just keep in mind that Black and Miles is definitely the Baltimore scourge. These are the things you will see everywhere. I put this one up there for me to remind you that heated tobacco is coming. It's received some kind of patent approvals or some such, so it should be coming down the pipeline. They're probably going to make that cheaper, so it'll become available. And the last thing to remind you is that this is very much in the market. So nicotine analogs are out there in the market. Your community that you serve is probably seeing these things. So just keep in mind that these exist, these are going to expand, and let us all be ahead of this curve. Resources for you, should you want to refer anybody, are, we put all of them on one page, but this obviously is too busy for today. But this slide is handy if you want to just download just that one slide. This is a very nice picture which shows you the kinds of lovely pictures you can show your clients or download for presentations, use them in your talks. And the idea being, of course, to scare them into stopping in this one. That you can entice them, you can educate them. Sometimes scaring also works. What to expect on this site, which is the Quit Now site. There's personalized coaching, and here's where texting will help you. If you wanted somebody who wanted a text coach, then this is a very good site to be on. You also want to remember the Maryland Quit Line at all times. And there is some detail on what is provided by the Quit Line on this slide. It's a little busy, but if you download this slide and stick it on a wall, it'll be handy for you when you're talking to patients. Also want to remind everybody that menthol alone, if they're just vaping or smoking or trying to smoke a cigarette with menthol or vaping menthol alone, it is shown that it may lead more to future tobacco use than if they were vaping any other flavor. Okay, so menthol alone is one of the pretty terrible flavors out there. These are some of the ways you can access them. It's available to you in multiple languages. So if a patient speaks any other language, you can look up the number that's slightly different sometimes, or the patient can go on this same main number and then click on the language that they need. Okay, I think with that, I come to the tobacco clinic that we have at the University of Maryland. In your folder, you should see this flyer. So take a look. And this clinic is manned by Dr. Janki Deepak and our two certified tobacco treatment specialists. Julia, can you wave? I think she has stepped out for a second. Colleen is right there. Julia's over there. So these are the folks who are our tobacco treatment coaches, and they are available on telehealth as well. The other thing to point out in your folder is this. This is a handy little card for you if you're talking to younger audiences. You want to use this because it talks about how you can talk to children, youth, and actually even parents. Um, and the language that you want to use is not "do you vape," which is usually the answer is going to be a no. But if you can try and say, "Have you ever vaped?" Or "in the last month, did you ever try a vape?" Sometimes you get a yes. So you have to vary the language depending on your patient, but um, it might work. And these guys, of course, do a very comprehensive tobacco cessation counseling, coaching, and they have had some pretty amazing success at this site. We will be doing a spring webinar series, and I put some topics on there. If you think of things you would like to see on there, please send it to us before we send in our CME request. But you will see some of these webinars coming in during the springtime, and anything else that's new, maybe some nicotine analogs or something that we might add. Okay, I think that's pretty much all I had. So if anyone has a quick comment or a question, I could probably take that now. If not, I'm going to move on to our next speaker. And all right, so today we have with us Dana Moncrief, who is no stranger to you all. She's the director of the Maryland at the Maryland Department of Health Center for Tobacco Prevention and Control, and she's been at the center for 18 years. As part of her role, she oversees the statewide tobacco control program, focuses on public health efforts to reduce youth tobacco, helps those who use tobacco to quit, and reduces exposure to secondhand smoke and vape. Recently, Ms. Moncrief has established a new branch at the center to implement programs addressing the public health impacts of adult use cannabis with a focus on youth prevention, treatment, and training for healthcare professionals and consumer safety. She holds a Master's of Health Science from the Johns Hopkins Bloomberg School of Public Health, a Bachelor of Science in Biology from the Penn State University, and is a certified health education specialist. So welcome, Dana. They want us to use this thing.
Okay. How do I? Okay. All right. Good morning, everyone. Thank you so much for coming out, and thank you for those online for joining us today. I'm Dana Moncrief, and thank you for that nice intro. And also thank you to TCRC for hosting 2 meetings and conferences in 2025. So we're very fortunate to be able to have our great team with TCRC and these great conferences. And I see we have 2 groups here, one on either side. Wayne, thank you for sitting in the middle. So let's get started. So I'm going to go over our FY25 updates and just really want to highlight too that we all need to be working together, knowing this environment that we have. Oh, all right, we'll just, am I doing this or you? Okay. All right. Roller coaster. So who feels like you're on a roller coaster right now? And those of you who have not raised your hand, please come talk to me at the end because I want to know what you're doing. It's not like this. So it's been quite a year, right? So there's a lot of things happening, ups and downs. I tried to find the most loopiest roller coaster here. And just that's how I feel right now. And I'm sure a lot of you do too. So we are here to work together, and I'll keep harping on that as we keep going through. But, we're all in this together for sure. So now where are we at? So Kelsey Holmes and our health equity work group have put together a list of priority populations that we're reviewing. This is based on social determinants of health as well as our data. And so you see our priority populations, Maryland youth who have experienced childhood trauma. this one? Okay. Okay. Hello. All right. Ooh, much better. Okay. Sorry. So this is really loud now. So Maryland adults who live below the poverty line and use tobacco, Maryland youth and adults disproportionately targeted by the tobacco industry, and Maryland adult frequent tobacco users who are at risk of tobacco-related disease. We also oversee the Cannabis Public Health Program. We have Erin Portillo here, who is our program manager. And our populations for Cannabis Public Health are youth prevention, persons and individuals who are pregnant and breastfeeding, and using cannabis and behavioral health populations. So here's some data that we have. So this is from 2011 to 2023, Burfus adult data. So you'll see that cigarette use has declined pretty dramatically since 2011. We're at 9.1%. And I have the two asterisks there because there is the 2024 Burfus data, not yet public, but we're down to 7.8%. So that's pretty amazing. Thank you for everyone. ESD use increased to 5.1%. It's about the same for 2024. Cigar use declined to 3.4%, and smokeless tobacco was consistent. Adult menthol use, so menthol products, this is a huge disparity. So 84.4% of Black adult smokers say they use menthol compared to 34.5% of white smokers. So huge disparity, and something we need to be, and even Dr. Khanna mentioned as well, really looking at menthol use. While there isn't as much of a disparity among menthol e-cigarettes, there still is a difference. And we should have added also LGBTQ populations who also use menthol at higher rates as well. In youth tobacco product trends, so cigarette use has declined dramatically since 2000. So by 86.5% for high school students, so we're down to 3.2% for cigarettes. And while there's been a decline in ESD use, you can see it's still the highest used product among youth. Cigar use has declined since 2000, although we did see among high school students a recent increase that was 3.8, I think, and up to 4.1 now. And smokeless tobacco use also declined. So also to keep in mind, this is the 2022-23 data. The 24-25 data, school year data, will be out hopefully early next year. With the government shutdown, we're still waiting for some of the data. So we'll, hopefully soon see these other results. And so what are we doing? You saw all the data here, high rates of ESD use among youth, also among adults, and what are programs that we're doing. We just talked about the Maryland Tobacco Quit line. I will just quickly go through, but it's 1-800-QUIT-NOW or smokingstopshere.com. It's free 24/7 tobacco treatment for those 13 and older. And it's for any tobacco product, including vapes. Free NRT, including patch gum, lozenges, and combination therapy. And then we have specialized programs for behavioral health, pregnant, postpartum individuals, Medicaid, menthol, vaping with youth populations. And we also, with the Quit Line, make referrals to local health departments. So this is a great partnership that we have with local health departments, and then vice versa. Local health departments also refer to the Quit Line. And some metrics that we have for 2025, there were 10,934 calls to the Quit Line, with over 7,000 enrollments, which is a 16% increase from FY24. We have a 37% quit rate, which is above the national average of 35, so that's great to see. And we're also able to calculate the return on investment, so $2.75, translating into $4.5 million in savings, and that's medical expenses, lost productivity, et cetera. We have our health systems approaches. Dr. Khanna referenced to the one of the grants that she has. So really nice overview here. So many Quit Line referrals from providers. Lots of trainings you can see for providers that can apply within clinics. 5 behavioral health facilities are also implementing tobacco-free policies. making recovery-friendly environments for those trying to quit tobacco use. We're also working with Dr. Galia Santos, and I think he's speaking later today. So we have a great initiative with them, and it's increasing referrals to tobacco treatment interventions and also increasing referrals to lung cancer screenings. And we are looking specifically at high-risk adults, ages 50 to 80 with a 20-pack year smoking history or who have quit in the last 15 years. They developed a toolkit. I just took a quick picture of it on my desk here, but a lot of great information for providers. And we have a really good response from providers, very positive. And you'll see in here, there's some cards that carry around, tobacco treatment pharmacology, billing codes, which is also really important, and then a book here about working with communities. So providers who are part of this initiative will get these toolkits. Oops, wrong way. All right, so I've outlined some of the state initiatives, so now looking at some local initiatives. So we do have the Tobacco, Diabetes, and Chronic Disease Prevention and Management Program. A lot of words in there, but it is a pretty novel program in that we're addressing that intersection of tobacco use and chronic disease caused by tobacco use. So you'll see working in the community, over 28,000 adults were educated through community engagement and outreach activities, over 23,000 youth were also educated through community and outreach. So thank you to the local health departments for all of your work. And you'll see also there are referrals to the Quit Line, but also referrals to programs that reduce chronic disease. So again, we're looking at that intersection. I put an asterisk here because this is a novel approach, something we need to be thinking about with the current administration. Seems like we're moving towards chronic disease. So how can we make sure we're including tobacco within these parameters as well? And then we have our CRF program with local health departments. 75 organizations worked with diverse partnerships. 19 schools were funded and over 57,000 students and teachers were educated on tobacco use prevention. 71,000 individuals were engaged by community engagement and activities. And again, you'll see a lot of referrals, not just to the Quit Line, but also to local health department programs as well. We have our mass reach health communications. So we've been running these for a while. We are looking at updating some of the materials. So the one on the left is Make This the Quit That Sticks. You'll see we have a lot of great reach, including the jukebox ads, which are in the middle. So that was something novel. We had over 10 million impressions on these jukebox ads. So they were placed in bars and restaurants throughout the state. And on the right is a focus really for providers, particularly behavioral health providers, really encouraging, including tobacco use in any recovery plans, tobacco use cessation and recovery plans. And we do have some additional targeted ads. So we are running the Active Aging Week. It's never too late to quit. The Pride. So this actually, Annapolis Pride was delayed till last weekend. Yep. So we have been running these ads as well. And then just some in the field images from Pride Month, in which a lot of the times we go out in the communities, we want to work with local health departments too. So we'll reach out and make sure we're collaborating with you. So we talked about menthol and tobacco use disparities. So several things happening at the state and local level. Certainly more to be done. So we did partner with an organization called Community Builders. And they're working with local faith-based communities in Prince George's County. I know they reached out, I don't see Eric, but reached out to Prince George's County, hello, Prince George's County Health Department to make sure that there was that collaboration. Again, they're working with faith-based communities and youth to provide tobacco education and community education campaigns. We do have special protocols, as I mentioned before, with the Maryland Tobacco Quit Line, specifically for those who use menthol. So there's up to 7 calls that are provided. And then there's also a Pathways to Freedom program as well. And local health departments, I know that you all are doing roundtables in the communities. Thank you. These listening sessions are so important. I know you all also have other faith-based partnerships and doing other things in the community. So certainly this is a great way to partner and make sure we're having a comprehensive approach. And there's also media and observances you'll see on the right here. We did do some ads for No Menthol Sunday. So this is a program through the National Center for Black Health and Equity. We're able to work with them. We're able to tag with our own logos. So it's really a great program, and I think it's the third Sunday of every May that we have No Menthol Sunday. Looking specifically at pregnancy and tobacco use, we had a partnership with WIC, so you'll see the image on the right is a one-pager that we developed. We also placed an ad in their cookbook that they put out every spring as well. Again, the Tobacco Quit Line has a specific pregnancy program with incentives as well. So this is something that we can refer pregnant individuals to, pregnant and postpartum. And then we have the Pregnancy and Tobacco Cessation Help or PATCH program. We funded 4 local health departments who had high rates of pregnancy and smoking. And you can see they were out in the field educating, also making referrals to cessation services, hosting community meetings and trainings, and providing guidance even on smoke-free housing for families, knowing that that's so important. And what are we doing for youth prevention? So we saw in the data before that ESDs are the highest used product among youth. So we have we have a media campaign, the Vape Experiment, which you all might be, well, Dr. Khan talked about it recently. And you'll see here, we're looking at avenues that are most used by youth, so Snapchat, YouTube. And we also just completed last month some focus groups, because there is a new campaign under development for both tobacco use prevention and cannabis use prevention. So we definitely learned a lot in those focus groups. So, excited to see what comes of this. And again, the Maryland Tobacco Quit Line has a youth portal and texting options. So texting vape free to 873-373, specifically for youth and young adults. And of course, there's state and local youth engagement programs. So specifically at the state level, we have Take Back Your 10. The youth members came up with that name, so it's Take Back the 10 Years of Life that could be lost from tobacco use. So TB10 for short. We are building momentum, so thank you for all who have been involved. So we're up to 20 counties, 4 chapters across the state, 5 youth advisory council members. So if you all want to participate, certainly contact Nasib or Lynette, and you can visit takebackyour10.org, and there's actually flyers out on the table upstairs. And we know with local health departments, youth ambassador programs, youth advisory councils, we saw on a previous slide, over 23,000 youth were educated by community engagement programs, and 19 schools were funded. So these are all great programs that we can certainly work together, state and local. We also we have a program with University of Maryland Prevention Resource Center, reducing tobacco-related disparities. And this is among LGBT communities, Black and Latine youth and young adults. Great program. They developed these wonderful materials, Live in Color Without Tobacco. So certainly, please visit the website. And Kelsey just reminded me we have copies of the toolkit that they put together, I assume out on the table. So this new toolkit is how to use the materials that we developed, where to place them, et cetera. So certainly encourage you to go visit the website, reach out to Kelsey, and there's more information out in the table. Tobacco retailer enforcement, we know this is also a youth prevention activity. We have 3 different levels at MDH of inspections. So FDA, we have commissioned officers. You can see they have several compliance checks completed, civil money penalties issued, warning letters. There was a recent FDA national operation. We don't know if our team was involved necessarily, but some of the things that they do at the FDA, they seized 4.7 million units of unauthorized e-cigarettes, totaling $86.5 million. And these came from overseas. We have our SINAR program where we do a statewide 10% sample. So there's an unannounced, randomly selected stores. And this is the kicker here. So the retailer violation rate must remain below 20%, or our friends at BHA, their substance use block grant funds, will be impacted, potentially up to losing 10% of their funding. So in 2025, we just completed in September, our retailer violation rate. We were in compliance. I was sweating it a little bit. So there's still work to be done, but we're below 20%, so I'll take it. And then local health departments, thank you to all of you at the local level. Conducting inspections on every licensed retailer in your jurisdiction, so thank you. We had over 7,700 inspections conducted in 25. So this isn't just the initial inspections, but also follow-ups if people were out of violation. And certainly all the local health departments conduct retailer education. That's so important. Thank you. And then it looks like there was 949 citations that were issued this year. All right. So we also oversee cannabis public health. So looking first at the data, again, this is before legalization happened. So again, with the new data coming out soon, we'll see, if there's any difference between before and after legalization, which was July 1st, 23. So the current cannabis use in Maryland among high school students is 14.4%. You could see it increases by grade level. Smoking is the most common, at least in the 22-23 year, was the most common mode of consumption. And you'll see here who is at risk. So current tobacco users used cannabis 69.5% versus those who are not current tobacco users. Those who are LGBT, those who are being bullied, and those who are feeling sad or hopeless, looking at that behavioral health connection, they all use cannabis at higher rates. Adult cannabis use in 2023, it was 13.3. It went up 14.7.1. So it did increase slightly in 24. And you can see among adult users, near daily use was the most common. Smoking, again, just like youth, remains the most dominant form of consumption. And current tobacco users were more likely to currently use cannabis as well. I know some of you are also working on the cannabis public health grants at the local level. So we have updated some of our materials in 2025. We're working closely with the Maryland Cannabis Administration, added some more features, I guess, to the Be Cannabis Smart campaign, particularly looking at youth prevention. This is more geared, though, towards parents, providers. So you'll see here, we just started the Talking to Teens About Cannabis. So this is a nice resource. Really encourage you to go to Be Cannabis Smart, download it, use it in your communities. We also have ads, Keep Cannabis Safely Locked, so safe storage. This is actually also a partnership with the Poison Control Center. So you'll see all the logos there at the bottom. And then at the very bottom left is Cannabis Isn't for Kids, and these are emergency room physicians, other physicians, pediatricians talking about why it's so dangerous for youth to be exposed to cannabis. We continue to, looking at consumer safety, continue to place our impaired driving ads, again, smoke-free spaces. And as I mentioned before, there's a youth prevention campaign that's forthcoming. Again, just finished our focus groups, learned a lot, felt really old listening. And then we're also looking at resources for pregnant and postpartum individuals. So we've reached out to our Maternal Child Health Bureau within the department and just looking at some campaigns that we're putting together. Again, local health departments, thank you so much. In 2025, the grant activities, and this was just starting, so it's so impressive. Over 21,000 youth, 646 parents, and 85 community organizations were engaged to talk about cannabis use prevention, consumer safety. So thank you all so much. In FY26, we're going to continue to work on youth prevention, elementary, middle, and high school, working with parents, healthcare providers. I know that's a big need that we've heard several times, but working with some providers and then again, like I said, pregnant and postpartum individuals. And one county is even in 26 assessing youth social media health literacy and its impact on knowledge and behavior. So we're really excited to see the results of that. We have our Cannabis Public Health Advisory Council. The website is there, and every year they have to issue a recommendations report to the governor. So the 2024 legislative recommendations report is posted on our website. Last week we just met, and I did approve the 2025 recommendations report, but so that should be released in December. And of course, we have our Legal Resource Center. I see Blair walked in. So they have tobacco and cannabis. Great resources. We're so happy to have them. And they certainly assist with training and technical assistance statewide. Here's the email for their cannabis program and the website. And then we're continuing our partnerships, again, with Maryland Cannabis Administration. We're also working with the Alcohol, Tobacco, and Cannabis Commission. There are some changes happening. There was an injunction that was lifted. So now intoxicating THC products like Delta 8, Delta 10 now must be sold in dispensaries. So there are some changes, and you can ask Blair for more details because I'm sure I didn't cover them all there. And then we're also working with the State Department of Education. Really want to educate nurses, guidance counselors, of course, teachers, and other professionals in the school system. Naseeb sat on the Standards and Framework Committee that they're going to release here soon, at least for public comment. So it's great to be able to interact and be on that process. And like I mentioned before, working with maternal child health, the Behavioral Health Administration, and even the Motor Vehicle Administration. So we now have a representative from the MVA sitting on the council. So it'll be great to hear their input as well. These are some resources, again, the Talking to Teens About Tobacco use, or Cannabis Use. Maryland Cannabis 101, there's a whole series of materials that the Legal Resource Center put together, and they're continuing to do additional resources. So you can download these. I put links in each of these. And then the Alcohol, Tobacco, Cannabis Commission, this is what they were handing out to retailers. I mean, we have the link here. I imagine they're going to be updating this soon based on what just happened with in the legal system. So, but they're all here. We all work together, and these are certainly resources available to everyone. Coming up, we are doing a program evaluation. We're working with SEA Healthcare. We're looking at our program of effectiveness. So reviewing trends, variation by race, ethnicity. Are our policies actually being effective? Are they equitable? So stay tuned. Some of you might be contacted, and hearing from us as we pull together this evaluation. This is important, particularly as funding is being cut. So we want to make sure we're approaching and have this data and information as we're applying for new grants or the like. So great information to have. Report releases. So the Maryland Tobacco Retailer Modernization Act report of 2024. That was just released in October. So we also contributed to this report about the impacts of tobacco and vaping. But the Alcohol, Tobacco, Cannabis Commission did take the lead on this. So it was due October 1st, and it is now published. The issuance of alcoholic beverage licenses to tobacconists. There was a work group that met 10 times over the last year. So that recommendations report is coming soon. And then, as I mentioned, the Cannabis Public Health Advisory Council recommendations report will be out in December. So where do we go from here? Be strategic and innovative. Like I mentioned before, we have our tobacco and chronic disease grants. Think about what's at the federal level, even the governor's initiatives as well. How do we make sure tobacco use, cannabis use doesn't get lost? So think and be innovative with your programs and make sure they're comprehensive. So everything I talked about, we have state, local, media, data. Make sure we have these comprehensive programs. And we're here to help too with data and materials. Work with other agencies. Continue your programs, expand and partner. I can't stress enough. Make sure you're partnering with others. Make sure you have these things in place. Amplify existing observances. November's coming up. There's a lot we can do just to talk about tobacco. Um, and again, please use our state resources. We don't develop them just for them to sit there. They're here for you. And we certainly want to continue our partnership, especially with funding decreasing or had decreasing. So you don't need to develop materials from scratch. Like, we have some materials for you that have been tested. So please reach out and we're happy to share. And then funding, I don't know what to say. I mean, the Office of Smoking and Health is no more at the federal level. Again, when you're hearing comments from the federal level, they're really going to focus on chronic disease. I don't know if that means funding is coming. But again, think strategically for things that might be coming out soon. And then most importantly, please take care of yourself. Find your why, partner, work with others. What brings you happiness and joy? These are my two new kitties, Lucy and Leo. We just adopted them last month, and they've been bringing me a lot of joy. So these I wanted to share with you as well. But please, please, please take care of yourself. Reach out, talk to us, talk to your colleagues, and find your happiness. And that is it for me. Do you want to, I guess, any questions?
We do have a question from online. Can you speak to whether there are quitline services for cannabis?
We were just talking about that. Unfortunately, there are not right now. I think this was explored several years ago, and David, you can correct me if I'm wrong, but it didn't have as much effectiveness as was anticipated or thought. So we currently do not. In talking with the Behavioral Health Administration, they actually said refer people to 988. And then there's also various at the local level and providers that also can provide some treatment and options for those, particularly with cannabis use disorder. Yep.
I teach nursing, and nurses who are going to own or manage assisted living homes. And we have huge assisted living homes that are being built now, 200 beds. And we're seeing an increased number of people using cannabis products.
Mm-hmm.
And because it's now legal, they're bringing them into the home, and they're not telling the nurses that are working in the homes that they're even taking it. So we can't get regulations on what we can do in these homes because the cannabis board won't do anything. The Office of Healthcare Quality doesn't want to step into it because people have their rights.
Yeah.
We're faced as the nurses that are working in these homes with dealing with this issue of gummies are a big thing. And we have no help. So I'm wondering if there could be some consideration maybe in looking at, I know we're talking about decreasing use or sensation or whatever, but maybe we need to also have some stuff put out for the elderly and use, and whether we just give them even warnings of this, because a lot of times, it's like, oh, my daughter told me I just needed a gummy and blah, blah, blah. So they take a gummy and they're out like a light.
Yeah.
And you're like, oh my God, what the heck is happening to these
Right.
people? And you don't know if it's their medications or what. There's no way, if the homes get federal funding, that creates another issue.
Sure.
And we can't store it and we can't give it out. And we have doctors that won't write orders for it because they don't know where they're getting it from.
Mm-hmm.
It's about to blow up and be bigger than what we think. And I was just looking at that thinking, I don't think we're even thinking about that. Or maybe we are, but it's not up there. So
Yeah, it's not that we're not thinking about it. We just got up and running in 2023, so we're still getting. But the Legal Resource Center is actually putting together a one-pager, right, for older adults. So we're reviewing that now. It'll be up on their website. But I hear you about having to regulate it. And, there's also drug interactions, right? So with cannabis, and you just don't know. So this is certainly something that we are working on. And also, as I mentioned, working with healthcare providers. So that would also include nurses and whatnot. So we certainly are, that's on our list, certainly. But thank you for bringing that up. Oh, okay. All right. Well, I'm here all day if you want to talk. Thanks.
Colleen cracks the whip. Thank you. So thank you, Dana. That was a very informative and wonderful talk. I am going to move us on to the next speaker, Joy. Is Joy here? Yeah, there she is. Okay. All right, our next speaker is Joy Kenner, comes to us from University of Maryland College Park. She is going to talk about language matters, youth prevention, tobacco prevention and cessation. She's a junior BS MPH student in public health practice at the University of Maryland College Park. Is there an echo or am I dreaming? Yeah, okay. With a concentration in health equity. She serves as a community outreach coordinator with the Prevention Research Center, where she works on Live in Color project. So she's going to tell us more about that. Advancing tobacco prevention and health communication among Black and Latin LGBTQ youth and adults. Joy's research interests include health behavior and communication, with plans to pursue her PhD after MPH. Congratulations, Joy. And so welcome. We're very happy to have you. I'm glad I could find you. You may have to speak into this. Thank you, Joy. So there's a clicker, and if you need help, right there.
Good morning, everyone. So as she explained, my name is Joy Kenner, and I'm an undergraduate BSMPH student at the University of Maryland. And the Living Color Project focuses on tobacco prevention and cessation in LGBTQ plus Black and Latina youth and young adults. So as an outreach coordinator, my goal is to, one, target our community partners as well as our target population. Now, I would like to say I'm pretty good at the outreach, but I would say I have a bit of a bias advantage because not only am I looking and studying youth and young adults, but I am an active participant in the target population. So as of now, I'm a little less than 3 years removed out of high school. And so a lot of the language I'm going to be talking to you about today have either formed or circulated by the time I had graduated. And this language is particularly important because this frames how we understand youth tobacco culture and communication and how much of this language actually goes above our heads as we study them. So I'll start with how language that the youth and young adults are using surround tobacco frames how their behavior around tobacco is understood, right? So hit feels a lot cleaner than smoke. I couldn't imagine going to a youth and young adult and saying, "You smoke." They're immediately offended. No, I don't smoke. I might vape, I might, have a couple hits, but I don't smoke, right? They can use tobacco products every single day for 365 days, and they would not like to say that they smoke, right? Nick sounds very casual instead of addictive. I couldn't imagine saying, "You use nicotine? Whoa, that's a lot," right? I might hit Nick, but it's not that serious, right? When they soften the language, they soften their perception of how serious their tobacco use is. So social media and nicotine culture has a very large influence on this. So online spaces transform nicotine use into a social norm through humor and relatability. So a good example of this is how TikTok and Instagram posts make vaping a part of stress culture. So as our predecessors might have said, "Woo, this was a long day, it was very difficult. I need to smoke a cigarette," for example. We have people as young as freshmen in high school saying, "Wow, that test in Algebra 1 was so difficult that I need my vape. I need a hit. I need a couple hits," right? And that's relatable. It's so stressful that this is the relief that we feel. And when you make memes and trends about your use, you frame it as self-aware. I know that I use these products. It may or may not be bad for me, but when you meme it, you make it relatable. Um, I'm self-aware, right? I'm inside the joke. But algorithms reward funny or aesthetic vaping content. I do not vape, nor have I ever vaped. However, the, let's say, algorithm, my For You page, whatever social media is pushing for my target demographic, has led me to more information about vape and tobacco use than I ever learned prior to starting college. These are real quotes from two very popular social media forums. X, formerly Twitter, right? I needed my nick to survive my finals. How would I survive my finals if I didn't have a vape, right? Your cart dies mid-lecture. Is anyone familiar with a cart? Okay, right? Cartridges, kind of artificial burners, can have nicotine. A lot of times it may be THC. So it reframes nicotine use as casual, social, or even ironic. So these are visual stand-ins for emojis for vape. I might text someone just the emoji in itself, maybe a older member of my community. Maybe I'm not legal and I cannot buy a vape myself. I might text maybe my older brother or someone else I know. Pick this up for me. You could go through my phone. Parents could read these texts and have no idea what I'm communicating to you. Memes about fiending or nick sick. Is anyone familiar with these two terms? Okay, so fiending. This is very common, right? Because the very common response to needing to use nicotine is, we'll say fiending, right? You've gone without, prolonged use to the point where you have an addiction, but they wouldn't call it addiction, right? Or dependency or anything along that sort, but you are fiending, right? Or nick sick, right? I've used it consistently and I can't go without it. Do any of these sound familiar? Right. Zen, we know about Zen, right? Chiefing. You might rip a cart. A dispo, right? A disposable product. Nick, cart, Benjamin is making its way around. I was already graduated by the time we started using this, so I was a little bit late, right? But a pen, similar to a dispo, similar to a cart, similar to Nick. If I, in front of my mother, said I was on the way and I'm going to buy a Benjamin, if I was in front of my teacher and I said, pass me your Benjamin, slide me the Benjamin, this is going over your head. This is entirely new coded language at this point in time. So coded that the first time I heard it, even I didn't understand it. So to reframe prevention, specifically the Living Color Project applies these lessons to centering language and culture and community prevention. So because we target LGBT plus and Black and Latina youth and young adults, some of our messages may be specifically targeting either LGBTQ plus or making references to Black or Latina communities. A lot of our materials come in Spanish, for example, but a large part of our communications is focusing on the language that the youth are using. So from the perspective of a young adult, I would say that the words, humor, and media we use matter just as much as the data. It is very effective, especially when we're looking at older young adults, to say, this increases your risk by X percent of your target population is at risk for this. And that is very effective. However, when there's a very lighthearted perception around tobacco use, the humor may be just as effective as communicating that same information. So the prevention starts with understanding the language, not correcting it. So if the youth are using nic instead of nicotine, if we're stepping in to say, not nicotine. The next time that another member of the community is speaking to another and another, and we say, use nicotine, they're outside of the circle. They're outside of the circle. It is no longer relevant. And those ideas are not transpiring. And if we want to change the culture around tobacco, we must start by speaking the same language. A lot of those terms that I mentioned previously, I can imagine over the amount of teachers, professors, mentors that I've had would let those terms go through a conversation and completely understand the context. Thank you for your time. So I know I have about 5 minutes left. So does anyone have any questions for me? Does anyone want to tell me which one of these? Oh, nope. Thanks. The word cloud. There we go. Any of these surprising? Are we familiar? Oh, yeah.
Hi, thank you for your presentation. Um, what do you see the remedy for um, correction or discipline in the schools? Um, from my small knowledge that I have, um, the suspension isn't really doing any good because they go home and they kind of vape for 3 days. Putting the detection devices in the bathrooms aren't working because they're fast enough, then the security or those that come to try to find who's doing the vaping in the school, and what kind of um, uh, platform can we give the staffers and the educators in school to make them more aware of the devices that the children are using? Because it seems that the manufacturers of the devices are getting so crafty that the teachers are having a hard time not only disciplining but detecting the use of the devices in school.
That is a really great question, and I can actually speak to this in a bit of detail. But starting with, of course, the language, they're talking over your heads, right? So you can be in the classroom and overhear an exchange of buying a vape and wouldn't know. There's also the understanding that there's kind of a common circulation around products in high school. Not everyone may have a vape, but a friend group of 5 people might be passing around the same exact device. So you may not catch the person who most frequently or most often use that vape, but you might catch the person who borrowed it from that person. Right? In addition to that, they're posting about it, right? They're posting about it. Now, I know that it's a bit difficult to kind of monitor what is circulating on social media when you are an educator or you're in the school system. But if you are promoting, advertising, or even doing a bit of overview on the language that they are using, it is all there. It is coded. And because of the coded language, if you're informing the teachers that, one, this is how this is circulating, this is how they're communicating in your own classrooms, and this is how you prevent, I guess, the spread of nicotine use amongst the population. Does that answer your question? Okay, thank you.
Some of this language is new to me too. I actually keep up with social media. And chiefing and fiending, I don't know how to use that. So if I was trying to use it with a group that I'm talking to, how do I do that?
So, chiefing is an easy one, I'd say. It is the repeated act of taking multiple hits, right? So, especially if you're sharing. If I'm sharing a vape, you're taking a hit and another hit and another hit, especially if you don't own it, you're chiefing, right? You're chiefing it. You absolutely are. And that could apply to, of course, if you own it yourself, but it's just the repeated use in rapid succession. So that is the context. Now, fiending is very similar to its normal connotation, right? You're a fiend for it. I would see this context used a lot in the absence of a vape, especially if you lose it. There's been multiple scenarios where you might drop a vape in a couch, you lost it in your backpack, it fell under a table. And if you've ever seen a young adult lose a vape, they will flip the house upside down, flip over the couch, interrogate every single person within the vicinity. They are fiending for it. Mhm. Thank you.
That was a fantastic talk. Thank you so much, Joy. And now we're going to take a 10-minute break and we're going to meet back up here at 10:11. Thank you all.
Cessation, and we have four wonderful presenters from local health. And I'm going to give a very brief introduction, and you can read their bios. The first person is Wendy Kelly. Kelly from Harford County, and she has been a tobacco prevention and cessation specialist with Harford County for quite some time. And she's going to be our first presenter. The next person is Paula Ernst, the person I probably have known the longest from local health. And Paula is from Washington County, and she's been with them for 25 years. And she is a certified tobacco specialist as well. Our next presenter is Susie Thompson, and she is working on her doctorate in social work. And she is the executive director of the Jude House in Southern Maryland. And our final presenter is Tammy Halterman, who was the Jones Stein awardee last year and was presented that award in June. And she is with the Calvert County Health Department. So please welcome them. And they will speak. The first person to speak will be Wendy.
Hi, everybody. My name is Wendy, and I'm from the Harford County Health Department. Thank you for being here today. I hope everybody got a copy of the tobacco bingo on their way in. If not, there's a pile of them everywhere. Grab one. All right, so I was asked to come up with, like, what would I do in the community? Or what do I do in the community that gets people's attention, okay? What draws them to go from pre-contemplation to contemplation, taking them to the next step? If you've ever worked with the homeless population, when you go in there, sometimes they look at you and they're like, "Ooh, I don't know, she's from the government. I'm gonna like go back to my bed and not participate," especially if it's a voluntary class, okay? So it took me a very long time to figure out what I was doing to engage them, lift their spirits, provide them with something that they don't get every day. Okay? We know that at least 75% of the people that are homeless are smoking. If they're not smoking, they're probably rolling cigarettes and selling them to the person that's in the bed next to them to make a little bit of cash. So tobacco is an issue, and it's deeply rooted into the homeless population. So when I first started doing tobacco bingo, I came across it on the internet, I do not get any endorsements for bringing this topic up today. It was very nice, okay? At first, I tried to play it like normal bingo. Well, that did not work at all, okay? So I had to modify it to the population that I was working with. Can we go to the next slide, please? All right, what I like about this as well is that it's easy. You don't need many supplies, okay? I got my cards. Everybody's got a card, right? Highlighters, dabbers. I have a bunch of these that I acquire through my own personal, when I go to charity bingos. Every time I go, I have to buy one because I forget mine. Okay, these are great. One thing you have to be careful of, I had a young lady, she was super young, okay? I want to preface that this tobacco bingo is for teens and older, okay? I use it for the adult population. I also want to make a note that this bingo was developed in 2003. So a lot of things have changed since 2003, and we'll get into that. But going back to the dabbers, which I will have this vision imprinted in my brain for the rest of my life. I was working with a bunch of really young kids, and the young lady, sweet as pie, she held that right up to her mouth, and she goes, "Miss Wendy, can I eat this?" Okay, no, you can't, no. My eyes got all big, and I'm like, oh gosh, here we go. So, knowing your population is important. I'm not gonna say that the first time, like I said, the first time I did this, I had run into problems. Sometimes I had to go in the shelter and just sit and watch and figure out what was going on. How could I engage them, and it took time. It wasn't something that happened overnight. All right, so everybody's got the prevention bingo card. The topics are why kids smoke, effects of smoking, tobacco facts, ways to say no, and smoking prevention activities. Can we go to the next slide? All right. So it was easier for me just to go down one column at a time. Why kids smoke would be the first game would be that one column, okay? So I'm gonna pull my first card. The first card says, why kids smoke? To look older. So you're looking on your card for the phrase, to look older. All right, I gotta take my glasses off because I can't read with them on. And then it has a little line under it that says the truth is that smoking causes wrinkles, yellow teeth, and stained fingers. Smoking will make you look older, but not in the way you want. Can we go to the next slide, please? Next card, to be independent. Anybody have this card? One person, okay. Sometimes kids smoke because they want to be free of their parents' control. But when kids smoke, it makes them dependent upon nicotine. So are they really independent? So what's good about these cards is I don't have to read the message that's after it. And sometimes, I couldn't do that for a whole game. But it brings out like conversation pieces. The next one, a relative smokes. Why kids smoke? Because a relative smokes. All right, so everyone is a winner when you play my games. I'm not going to send anyone home without a free bus ticket or something for participating. Incentives are so important when engaging certain populations. You can't win more than twice. So when I first started playing, I'd have 2 people show up. Now I have 15, 20, okay? Most of these people have been outside in the rain and in the snow and the 100-degree weather all day because they're not allowed in the shelter during the day. But to have them come to my class is such a joy. But it's mostly, the engagement that we've done over time. It is the incentives that I give them, bus passes, flashlights. These are homeless individuals, solar chargers for their phone, backpacks, bus passes. Can't stress that enough. $1 bus pass. To have an individual come up to me and be like, "Yay, I can go to my job interview now, stress-free." Or, "Oh, I could, my medical appointment, yay, I don't have to worry about, bumming, somebody for a ride because you gave me a bus pass." It's like gold. If you're playing bingo, next card is media influence. All right, so when you're doing a budget, a lot of these gifts are about $15 nowadays. I used to like to keep it under $10 each. But unfortunately, prices have gone up. Next slide, please. All right, so there's 101 reasons why somebody doesn't want to participate in my class. Not that they don't want to participate, but maybe they can't. Maybe they can't see. They haven't had their eyes checked in 20 years, okay? Maybe they didn't sleep last night because, they were sleeping out in the rain, okay? There's a gazillion different medical, psychosocial reasons why people, are gonna struggle during class. So to be able to bring them something like tobacco bingo really just, it lightens their day, it lightens my day, and, it's like, I believe there was a message earlier about find your why, and to be able to serve the community. And now when I see them in the streets, they're like, "Hey, Miss Wendy," and so they're thinking about smoking, not smoking, because they see me, and they're getting used to me. And that's so important, especially in today's society where it's like you'll have a healthcare worker come out and then bam, they're gone. You never see them again. People aren't opening up because, it's like, why, Next slide, though. So, ability to manage challenging behaviors, setting limits. We get a lot of chatterboxes in class. So I like to hand out lollipops. That really helps calm people down. A lot of people we work with, they have addictions. They got the tics. They're ready to run out the door. So to be able to calm them down, refocus them, you can do that in many ways. I always say I try to get the senses going. Smell, taste, touch, keeping them connected to the here and now. Their nervous systems, are just, the fight or flight's kicking in and, so there's a lot of things to worry about. So I think I covered all of that. Next slide, please. All right. If you ever want to buy the tobacco bingo, there you are. That's the place you can buy it. It's super cheap. All right. If anybody's still playing bingo, why kids smoke? To be cool would be your next one. And we're staying in that same column. I'm just going to go straight down till my time's up. Lack of coping skills. All right. I'm going to repeat what I have so far because we have lack of coping skills, to be cool, media influence, to look older, a relative smokes, to be independent, to relieve depression and anxiety. Any bingos yet? To experiment. Experimenting with cigarettes is like experimenting with jumping off the Golden Gate Bridge. It will harm you. So if you want to experiment, do it with things that can't kill you, like sports, hair color, music, or clothes. Next one, why kids smoke? To rebel. Good one. Why kids smoke? Peer pressure. Any bingos out there? Yay! All right. In the top right corner, there's a number in a circle. If anybody else has that number, they probably have bingo too, because it's the same card. So if you weren't paying attention, but congratulations. I have a little prize for you. All right. So next, I have 2 minutes left. Oh boy. All right. I guess I'm bringing you your gift. All right, so tobacco bingo. Now, I don't do tobacco bingo. Well, I do it monthly at the homeless shelter. At the day program, I do it at quarterly. There you go. You get a lollipop. Congratulations. All right. All right. Thank you, everybody.
Good morning, everyone. My name is Paula Ernst. I've been with the Washington County Health Department for 28 years, and I've seen a lot of changes through the years, but I've also seen that some things never change. Tobacco use continues to be the leading preventable cause of illness and death in our country. The tobacco companies continue to manipulate the truth and target our youth, and quitting tobacco is rarely easy and relapse is high. A quick story. So every Tuesday, I go to visit my three little grandkids an hour away. I come with a little blue bag that has a little surprise for them in it. And as soon as I walk in the door, they say, "Did you remember the blue bag?" That's all they care about. So, and as you can imagine, rather frequently, the blue bag does not live up to the anticipation of its reveal. Well, I must admit, when I saw the agenda topic, innovations in cessation, my initial reaction was much like the folks in my group. It was kind of like, oh, I hope there's going to be new alternatives, things I've never heard of, a new prescription, or maybe a magic potion that will make it easy to stop using tobacco. Now let's see if this is going to work. Where am I pointing? Go down. Oh, yay. Oops. So we're going to take a tiny trip down memory lane. I think it helps to see how the program has evolved through the years to meet the needs of our participants and our community. In 1995, we started with the Stop Smoking for Life program. You can see we used bright colors, definitely drew everybody's attention. Up in the right there is our health officer at the time who put that shirt on, and he was talking to the media in that. And I'll tell you, in 95, we wore those shirts everywhere. Literally if we were at this conference right now and it was 95, I'd be wearing the yellow shirt. But that consistent marketing worked. People recognized us. And at the conferences, everybody would say, "Here comes Washington County." At that time, our groups were meeting twice a week for 4 weeks, so 8 sessions, and we offered them about 4 to 6 times a year. And the format started out very structured. In fact, the very first, I wasn't there actually quite then, but the very first classes, they thought what we'll do is have everybody quit together, and won't that work for everyone? Well, when the big quit day came, you can kind of imagine what happened. So, but realizing that the journey to becoming tobacco or nicotine-free was as individual as the folks in the group, it set the tone for the future of our program. And I like to point out in the middle there, that's a billboard we had up back in probably 95 or whenever. And notice it says 4,000 chemicals. And of course, now we know 7,000 chemicals. So a lot has changed. During that time, we also had the opportunity, because of some small grants, to provide acupuncture, EMDR therapy, and a meditation-based intervention at no cost to the group. It was like some folks in the health department were doing little studies. And, we had high hopes. These are some new interventions, but, and some people really benefited. And of course, some people, it did nothing. So we were happy with the possibilities, but no major changes. So in 2000, along comes the Cigarette Restitution Fund, and of course we had more staff and a lot more funds. And we were able to provide nicotine replacement therapy. And actually, the fact that we had started in 95 with just a beautiful database, that's why I have to have these notes. What was that word? Database. Perfectly planned out, where we follow people for 2 years. And it caught the attention of Dr. Anthony Alberg, he was an epidemiologist working through Hopkins at the health department at the time, and he decided he wanted to analyze our data and take a look at folks who were quitting before NRT when it first started. Of course, we had nothing. It was cold turkey. It was available over the counter, but of course, nobody wanted to buy it. And then we got NRT, and that he wanted to look at the difference there. So in 2004, he analyzed the data, and a number of things changed pretty quickly. Enrollment went up 42%, and we had waiting lists. It was so unheard of. I mean, we literally had to have up to 20 people in the group with a waiting list. So it was totally different. Our baseline quit rates went up from 38 to 66% when we introduced NRT. But the factor most strongly associated with quitting was the number of cessation classes that they attended. And notice there at the bottom, I just wanted to show you that 10 years because I happen to have that number where 1,806 folks attended classes. Pardon me. Through the years, we've always offered classes at least twice a week. So class length, though, after the study, we realized quite a bit, that we could use to help benefit our program. So we reduced the classes from 8 to 4. People, by the end, people were totally, dropping off. The people who were struggling didn't come back. So we would sometimes end up with 2 people in the group at the end. So we decided to shorten it up to 4 weeks, which also allowed us to offer it more often so that people weren't having to wait so long to attend class. And once they were shortened, the funny thing is here we were in 4 sessions, and at the end of the 4 sessions, those who were highly engaged, they were like, oh my goodness, don't end the group. We really, really, need support. So then we decided what we need to do is add a little support group at the end, 2 sessions at the end, and they can just come back. Well, absolutely nobody came to those little 2-session support groups, so you never know how things are going to work out. Our current group is set up as an open, ongoing support group, providing both in-person and virtual. And of course, that's a little benefit of COVID if we think about it, right? We would never probably have done virtual classes. But individuals can join anytime, come as often as they'd like, and disappear and come back as their journey evolves. We did increase the nicotine replacement to 8 weeks. In the study, it was only 6. And that was kind of in the discussion of the study. There was a great quit rate at the end of group for those using NRT. But it was, what happens is after about 2, we would follow them at 2 months, 3 months, I can't remember. There was a huge drop off in the NRT group. So it was discussed that maybe they just needed the 8 weeks, which of course was the protocol. We just only gave 6 because we didn't know if we had enough money. Okay. Eventually our program name changed to Tobacco Free for Life to kind of address obviously all tobacco products. And we all, again, tried to keep our marketing consistent, as that other one was the bright yellow. We kind of kept a little bit of that and then introduced this fun guy. This table shows number of participants and number of classes held for the last 3, almost 4 fiscal years. The number of classes reflect the 3 classes held each week at the health department, as well as community classes. And we actually go out to treatment centers, the Hagerstown Housing Authority sites, and Soul Haven, which provides services to those experiencing homelessness. In 2004, you'll notice our numbers were, wow, great. We actually had a little bit of extra money. We had some salary money that we were able to shoot over to NRT, and that helped us reach a bunch of people. But we were still kind of under the COVID guidelines we set up. During COVID, obviously, people couldn't come in. We didn't do groups for a while. Then we did all virtual. But they would swing by the health department, pick up their supplies, and off they go. And that was kind of how it worked. So then we had them have to meet with a cessation counselor at least to sign in and talk and get supplies. And we had kind of had it like that for a while. So our numbers were really good. But then in 2025, we went back to our original, which of course we all know, NRT plus gum plus lozenge with support is going to give you the best chance of success. So we wanted, and it always was, support. But the interesting thing is that although there were many more participants registered in 2024, you'll notice that only 14% of them attended 3 or more sessions. Whereas in 25, when we had them, it was mandatory to attend group to get supplies, 43% attended. And once again, persistence pays off. I mean, the study showed us that the more sessions folks attended, the more likely they were to quit. So being able to look back at the study results and what we learned from that continues to provide guidance to our groups and how we organize them. And it turns out that the primary innovation is being open to change with respect to how we organize our groups and as a mindset of being ready to change for our participants. There's no one size fits all in cessation, we know that. But we can have an arsenal of strategies in our blue bag. Sometimes they will be cause for celebration and other times they will fall flat. Innovative strategies give hope. And so consistently we bring them to the table because those wins are always so worth it. Thank you.
We'll give them time to get the PowerPoint switched over. All right, I'll just start by introducing myself. So my name is Susie Thompson. I am a licensed master social worker. I'm also the executive director of the Jude House. For those of you who aren't familiar with the Jude House, we are in Charles County in a very rural area of Belle Alton. If you haven't been there, it's very south of here and very, very in the country. But we like it there for that reason. I wish I dealt with little babies like that, but I do not. That would be us. Yes. It's okay. We're all good. If we can go back one. There we go. All right, so we're here to break the cycle, and it's smoking cessation at the Jude House. So like I was saying, we are a drug and alcohol rehabilitation center, but we're a little bit more than that as well. We're also a recovery community organization. And so what that entails is basically where our smoking cessation comes in is in our 6-month inpatient residential treatment program, but we also have outpatient services. We have community trainings. We have men's sober living home or a recovery home. We have pregnant women and women and children's home. And that is in La Plata, and we do have beds open. So if you know of anyone, just let me know. Oh, that's on here. Sorry, I'm trying to figure out the technology. Okay, so our population, basically I wanted to start real quick just to let you know the reason that I'm here is because this program is very near and dear to my heart. I went through this program myself through the health department in Charles County in 2015. I smoked for 20 years. I can tell you anything you want to know about smoking, when it comes, how it comes. And I wanted to quit. And one day when I wanted to quit, I had the help that I needed. And so it was so important to me when I got into this field. I went out and I spoke to the same person that taught my class, Mary Beth Click, at Charles County. And she said, "You want to teach these classes? Absolutely. We're so excited." And so we ended up getting a grant for that. And it's been going on ever since. It's actually, we're on our 4th year, which is pretty exciting. So it is near and dear to my heart. I know where they're coming from. I know how to have these conversations, and we are very interested in getting that word out. So our population is a little bit different. It sounds very similar to some of what people have, but we have the advantage of having them inpatient, so they are stuck with us. They don't get to go anywhere else, which is great. And so we we educate every single person that comes through our building. So whether you're a smoker or you're a non-smoker, we want you to have this education because it could benefit you or your son or your daughter, or your grandkids, anybody that's involved. So the majority of our residents are smokers. You are a minority if you are not a smoker, and that even goes with staff. Some of our staff, there's a lot of staff that are smoking too, because we're about second chances in recovery, and it kind of goes hand in hand. Unfortunately, you'll see that. They're dealing with high rates of trauma. Most of our patients are coming from incarceration, so you've got that as well. And then there's co-occurring substance use and mental health disorders. It's very normalized. So if that's the norm, if that's what you're used to, if that's what you grow up with, then you don't know any different. And it's just what you do. Yes, there was those things that I heard, talked about it being cool, things like that. And that's one of the reasons, but it really is the norm for them. And then it's transformative. So we have to come up with some creative ideas to get them to quit. Just so you know, this particular picture, these are actual staff, patients, family members. And this happens to be our band. So we have a Jude House band, and they're pretty amazing, just so you know. I have their consent just as well to use these. And so year one was FY23. It was our first year. We actually didn't get the grant until it was halfway through. So we didn't get to help as many people as we wanted, but we got all of our equipment that we needed to do that. So it turned out to be really good. We did help 37 participants. And our main goal is really to show no shame. There's no shame in this. There's no judgment in this. It's all about education. How are we going to get them to come to the table and then learn, what's happening to them? They're being targeted in certain areas? Like somebody's making a lot of money off you. Do you know that? Do you know how much money you're spending? And just having some of those conversations. We're not here to have you quit. In fact, you don't have to even come up with a quit date. We're not concerned about that. We're concerned about planting seeds. We're concerned about showing you that it's not the norm, and we're concerned about educating you. So we had 3 staff members that created quit plans, and then 1 that quit entirely. We did introduce stages of change, some coping mechanisms. We do give the NRT as well. And just like I've heard other people say, they love to come to our groups. So at first they're like, I don't want to do this. I don't even smoke, or I do smoke, or I quit a while ago. And then they're like sneaking back. Can I come into your group now? So it's turned out to be one of the favorite groups that they have. She is on it. Okay, so year 2 is our FY24 highlights. We obviously figured out things a little bit better, right? So we had 72 patients that went through the program. Is somebody doing something on here? Oh, okay. So we, our target was 80, so we were a little under that. We had 82 referrals to our Maryland Quit line. 7 patients quit smoking, so that was a big win for us. We're super, super excited about that. We had 5 that reduced significantly. Again, those are some of the goals that we had. We're not trying to make anybody quit. In fact, if they just want to have a quit plan for once they leave out of there, because it's much easier to do once you're out of that environment, that's good for us. Like, we're okay with that. We had 2 staff members that made strides towards quitting. I'll tell you, the patients are doing a little better than staff. And they like to gloat about that, and we let them. And then one of the biggest things is that we need to do smaller and longer groups, and that's what we learned. So it's 10 or under in the groups, and we have them for about 6 to 8 weeks, depending on what time we have frame in there. That's it for that. So year 3. We did 60 patients. We did serve mainly males. At the time, we had male and female. We currently only have males in our programs at this moment. And then we have 25 that had mental health diagnoses. We had 12 that started Chantix and 9 that used nicotine patches. And this all goes about who is going to, what's the norm? So if somebody is going to do Chantix and they say, hey, it worked for me, then everybody in that cohort thinks that they need to do Chantix that year. And if everybody says, oh, but this worked for me, never mind what us experts say, right? Like, we don't know what we're talking about, but what if the person sitting next to them says, oh, the patch works for me, then they're all going to do the patch. And so, we go with the flow, whatever works. We did get 2 new facilitators formally trained so they can see other people besides for me. And so our impact and next steps, over 3 years, we did serve 169 patients. which we were really excited about. They at least engaged in the cessation services. They had the education. They have the tools that they need for while they were there or when they walked out. We have staff wellness gains. We definitely, in the future, would like to expand staff training. We are doing harm reduction models, but we want to integrate everything. We want to strengthen our community partners. And we want to put it out to maybe our outpatient services and some of our sober living homes as well. And we were just awarded the cannabis education, so that is a new program that we started this year as well. And this just goes towards our mission, right? Our mission is about breaking generational cycles of addiction, and that definitely includes tobacco. So, thank you.
All right. I'll introduce myself. I'm Tammy Halterman with Calvert County Health Department, and I've been there a very, very long time. I don't know if I want to say how many years, but I have worked with the Cigarette Restitution Fund program since 2005, so in many capacities. So the patch program, Dana alluded to it earlier today, is a public health initiative that is designed to reduce tobacco use among pregnant women and women of childbearing age. And it was targeting the rural Maryland jurisdictions that had historically high smoking rates at the time. So, next one. In 2014, Dr. Sharfstein was the health secretary at the time, and he was very concerned about the smoking rates during pregnancy, but also how come they weren't taking part of the quit line services and local health department cessation services. So he directed his staff to find out what the problem was and to do something differently. So Dr. Shell at that time, he contacted more than a dozen local health departments in the rural jurisdictions to meet with providers in their community, partners in their community that worked with pregnant women and women of childbearing age, and to get their input. And then the PATCH program, which is Pregnancy and Tobacco Cessation Help, was developed. And the key components of that was to incentivize partnerships, to provide training, and promote system changes. And so it was working with partners such as pregnancy care centers, OB/GYN offices, pediatric offices, their home visiting programs, those type of programs. And I believe there were 10 jurisdictions at the time that back in 2014 that started with the PATCH program. And as Dana shared some of the materials that were used, this just gives a snapshot of those. And there was the incentive gift program, gift card program, the one on the far left. She shared the purple one, which is the more recent WIC handout one. But in all of these, it was about building capacity to increase referrals to the quit line and the local cessation programs. Hoping that people would have more brief interventions, not just ask if people smoked and say, here's a card, but to have more brief interventions and system level changes with those. And so one of the things that you could do with these is use them in different ways other than just a handout. You could make them into retractable banners. So we did that with a lot of them and put them in the pediatric offices, the OB/GYN offices. You could put them in newspaper ads to help promote. At that time, in 2014, newspapers were still a big thing in communities. And then they could also hand them out as well. as handouts. And the pictures with the babies on them definitely grab people's attention. So that using that really did help. The next slide shows just a few data points. When it first started, 2012, they used the prenatal risk assessment, and 26.6% of women smoked during their pregnancy at that time. So Calvert County actually continues to be one of the 4 counties. This is not a good thing to continue the patch program because it's based on smoke data. So we went from about 10 consistently down to 4. So good for the other counties to make those strides. And then across Maryland, a more recent fact that came out, 24% of the infant cases that were reviewed for the SUID, the sudden intrauterine unexplained deaths, the infants were exposed to secondhand smoke. So we still have a lot of work to do. Just to give you some ideas of what Calvert County has done is we have partnered with our Family Daycare Association. They have become a very active participant with trying to reduce smoking and secondhand smoke and with tobacco and cannabis. We held a training for providers. It was called Healthy Lungs, Healthy Life. And then this past year, there were 99 daycare providers that participated with the training that they offered back in March. And then another big partner is our Calvert County Public Schools, our Healthy Families program. That is a home visiting program as well. And they are the ones to host the community baby shower. And we had 63 families participate in that this past year, and 30 pledged to establish rules for smoke-free homes. So that was wonderful. We have 4 pediatric offices in our county. We had 3 participate with the program, and they would put up the retractable banner that you see on the right-hand side in their offices, which generated a lot of conversation with kids. Even my granddaughter now goes to one of these pediatric offices, and she, when I saw her one time, she was like, "Gimme, did you make that poster in my doctor's office?" And with the help of a printing company, yes. But anyway, she was like, "That is so good. Did you know this is what it does? This is what happens?" So we know kids are reading it and talking to their parents about it. And so they also would take the bibs. We did No Puffing Around Me with the puffin little penguin. So the nurses, when the babies would come in for their 2-week checkup, is when they would give the bibs out to the families. So that it's been a nice partnership there. Our Calvert Health OBGYN Center has revamped their OB services and doing that whole system a little differently. So for a while, we weren't taking new OB patients. They were going to surrounding counties. But once they got up and running this year, they were asking for, what can we do to partner with you? And they have a nurse navigator on staff that is a real key to educating the patients and making that connection for assistance with cessation. And then internally, we have a reproductive health clinic, and we have the home visiting, the Healthy Beginnings program as well, working with pregnant women. So we have different materials that get mailed to homes through those programs, and then those internal connections, which make it nice. Oh, yep. Nope, that was perfect. And then we did a theater commercial.
First sticker of the day when I get up. We smoke in the car on the way to school. I smoke while I'm coloring. I smoke during my nap.
When you smoke around your kids,
I'm down to about a pack a day.
it's like they're smoking. Secondhand smoke can hurt their lung growth and permanently damage lung functions.
I tried quitting. I need to try again.
Secondhand smoke, it's nothing to kid about.
So that's an attention grabber for sure. So we played that at our local movie theater before, when the ads are running. And you get a lot of calls and comments when you're in the community, where people stop and say, I could not get over that commercial. Those kids are so cute. So you use any tactic you can, right? And then lastly, I'll just end with the accomplishments. And these are the four counties, Allegheny, Calvert, Dorchester, and Washington, that have been involved with Patch for a very long time. And you can see all of the rates have gone down. So wonderful. And for Calvert County, we are just above the Maryland line of the statistics there. So everybody is working hard to get those rates down and make those accomplishments happen. Thank you.
So we have about 10 minutes for questions, about 8. Does anyone have a question for any, I'm sorry, don't mean to stand in front of you. Does anybody have any questions? No? Then we have another 7 minutes.
I have one question.
Okay.
Where can I find that commercial? That be my email. Thank you.
Great, well, thank you, everyone. Thank you, you were all 10 minutes. And you were 9 minutes. Wow, I saw you. I didn't want to be. Yeah.
Okay, so thank you all for a wonderful panel. Let's give them a round of applause. So we're going to move on to the last session before lunch, and then we may have a slightly longer lunch, which will be good, I think. So our next session is about perspectives in tobacco and nicotine use, or NIC, as we were just told. And we have 2 speakers in this session, both of whom I think haven't been to our best practice advisories previously. Oh, yeah. Sorry. I'll turn off. Okay, our first speaker is going to be Chris Bostic. Chris is an attorney and a policy director at the Action on Smoking and Health. He chairs the National Steering Committee for Project Sunset, a campaign to phase out the sale of commercial tobacco products, and co-chairs the Global Steering Committee. Chris has worked on tobacco policy at the local, state, national, global levels since 2001. So we welcome Chris.
Stand here. I can see the screen. Okay. All right, first, sorry about the date. This is what happens when you recycle slides. I think that's the only typo in the whole thing. Thanks for having me here. This is very exciting. Like I said, I've never spoken to this group before. Let me start by asking, does anybody not know what endgame is when we talk about it in the tobacco context? Great. I don't want to speak to the choir all the time. So I am the policy director at Action on Smoking and Health, and I've been doing this for about a quarter century. And about 10 years ago, our board decided that we were going to do something different and change the way that we think about the tobacco epidemic. And for me, this is the biggest change in best practices since I started in this field. And the idea is that instead of mitigating the tobacco epidemic, we should be working to end it entirely. Is this the one? Oh, down here. Oh, that makes more sense. Okay. First, a little background on how we came to this realization at ASH. We use what is called a human rights-based approach to tobacco control, and we started doing that in 2014. And when you look at the tobacco epidemic through that lens, through that human rights lens, you come to an obvious conclusion, which is that governments have a duty to do something more than mitigate the tobacco epidemic. The tobacco industry is doing something that is a violation of human rights simply by marketing and selling products that they know are going to addict and kill when used as intended. Oh, I should also warn the audience, I'm going to be using some dirty words like equity in this, so if you're worried about being called a terrorist, turn your TV off or whatever. So our first big victory was in 2018 at the World Conference on Tobacco and Health in Dublin, South Africa, where we got the global community of tobacco control organizations to adopt the Human Rights and Tobacco-Free World Declaration. And in the first paragraph, it says just outright that the marketing and sale of tobacco products is itself a violation of the human right to health. And then we followed that up in 2019 with the Human Rights and Tobacco-Free World Global Forum in Bucharest, Romania. It was held at the Presidential Palace, and that's the president of Romania speaking there in the beginning. And the idea here was we had already convinced the tobacco control world that they ought to be using human rights in their work. This was to convince the human rights world that tobacco ought to be something that they're working on. So this was another big success. And now most of the human rights commissions in the world do include tobacco in their work. And by that I mean when they're talking to a country about upholding basic human rights, they ask them about their tobacco policies to make sure they're doing all they can. So what a human rights-based approach tells us about the tobacco epidemic, there's several things. First, health equity is paramount, and we all know that. It's a problem in this country, it's a problem in every country, that the tobacco epidemic impacts different communities differently. And we've left a lot of people behind in the work we've done over the last 70 years. The second is a big change in the way that we think about tobacco policy. And it's that governments have a duty, not just a right, to stop the tobacco industry. I've been an advocate my entire career, and I always, in the past, would go to a government sort of hat in hand, begging them, can you just do something more on tobacco? We've stopped doing that. We go to them now and they say, you have a duty to do this. This is what governments are for. And you're letting your people down by not doing more about the tobacco industry. Third, it switches the way that we think about the cause of the tobacco epidemic. It's the industry that's the perpetrator. When I started, I think there was sort of a shameful period in tobacco control when we blamed people who smoke. And if those darn smokers just quit, the tobacco epidemic would go away. That's not the problem. They're being addicted as children. And governments are allowing the industry to prey on children to get them addicted to a product that's very likely to kill them. So this is about going after the industry. It's about going after supply. We still need to do all those demand intervention things that we've always been doing because the product is still out there. They're very important, but we have to add on to that. We also have to go after the supply. And then, of course, people who use tobacco are our clients. We're in public health, and if we're trying to save lives, there's no bigger group of people that we ought to be focusing on than the people who are already addicted to nicotine. There's 1.2 billion tobacco users in the world, and more than half of them will die unless we can stop the tobacco industry. And finally, cessation is absolutely vital in endgame. We cannot take away access to an addictive product without helping the people that are already addicted to it. And I've been very happy to hear what I've heard so far today. So in 2018, we launched Project Sunset, which has a very basic goal. It's to phase out the sale of commercial tobacco products. At the time, we were the only organization in the world that was thinking this way. We put together a steering committee in 2018, and the Truth Initiative was there from day one. They've been our strongest supporters since we started our endgame work. Today, it's become much more normalized around the world, and especially outside the United States, as you'll see in a moment. So there's two imperatives to Project Sunset. The first is that we're going after sales, not purchase, use, or possession. When a jurisdiction comes to us asking for technical assistance to put an endgame policy into place, if they want to legalize the purchase, use, or possession, or they're not willing to get rid of those laws from their books, we won't work with them. This is about the industry, not about the people who they're, not about their victims. And second, there has to be access to cessation in place. It's absolutely imperative. So what is endgame? If you follow this debate around the world, there's a lot of different ways of thinking about it. For some people, endgame is, oh, let's just keep bumping up taxation until nobody can afford it anymore. That's not the way we think, but we don't think there's one definition that's correct. There's a wide variety out there, and they're not all wrong, and a lot of them can work together. Second, it really operationalizes our collective vision. Like most tobacco control organizations, since its founding in 1967, ASH's vision has been a world free from the death and disease caused by tobacco, not a world where we perpetually mitigate the damage caused by tobacco. So when we went to our board asking for this change, it was a pretty easy ask. We just said, you adopted the vision, so let's live it. Endgame is not simply pressing harder on those demand functions, demand policies that we've always done. Again, very, very important to keep those in place and to strengthen them, but this is about something a little different. Endgame also has a deadline, and we all have this vision someday the tobacco will be over, but it's always over the horizon. It's just, oh, my grandkids won't live in a world with tobacco. We need to make that happen sooner. And endgame, the date is going to vary because there's different contexts, different places have different parts on the journey along tobacco control, but it can't just be someday. Endgame also addresses tobacco as a systems issue rather than a behavioral issue. This is about the government being in bed with the tobacco industry. And there's something kind of perverse about a government taking in hundreds of billions of dollars around the world in taxes and then using a tiny amount of that money to tell people not to buy the product, and an even tinier amount of that money helping people not use the product after they've already become addicted. And then, as I said earlier, endgame shifts the focus from demand to supply and from the victim to the perpetrator. So some of the other definitions that have come out there, and we work with all these groups. The Project Sunset definition is very clear and simple. California, 6 years ago, almost around the same time that we started, began their own tobacco endgame program. This was the definition that they adopted. It came from Dr. Ruth Malone at the University of California, San Francisco. Truth Initiative came out with their own manifesto in 2021, I believe. And that's the definition that they put in. And then another simple one as an example from the Spanish National Coalition, Non Fumadores, Make Tobacco Consumption Disappear from Spanish Society. So one of the things we're trying to do is get rid of that word control. And it's hard because we've always called ourselves a tobacco control community. 3 years ago, the California Tobacco Control Program, which is one of the oldest ones in the world, it started in 1989, changed their name to the Tobacco Prevention Program to get rid of that word control as an indicator that they're in this to win it, not just to keep mitigating it. So earlier this year in June, alongside the World Conference on Tobacco or Health, we held the first global endgame summit in Dublin. It was standing room only in the room. The difference is amazing. When we first started talking about this 10 years ago, the reactions we got ranged from "you're crazy" to "you're dangerous" to "this is pointless and you're wasting your time." Now it's become normalized, and most groups around the world have adopted tobacco endgame as part of their basic work, with some notable exceptions, which I'll talk about in a moment. And then earlier this year at the national conference, we had our second national endgame conference. And again, even though the NCTOH was hit hard by CDC OSHA's closing and the lack of funding around the country, we had to turn people away from the endgame conference. And some people actually came to Chicago for the endgame summit that weren't coming to the NCTOH. So some progress around the world. We'll start in the United States. We have now, if you haven't heard of endgame, this is going to be surprising to you. We have 24 jurisdictions that have passed endgame laws in this country. The first two were in California, Beverly Hills and Manhattan Beach 5 years ago, banned all tobacco sales. And I'll talk in a moment, a third one joined them last week. We have, in Massachusetts now, there are 18 towns that have passed what we call nicotine-free generation. And that's a policy where you set a birth date. Anyone born after that date can never be sold tobacco. So it's a sales ban with a grandfather clause, basically. The 18th just came 2 weeks ago. There are 3 towns in Minnesota that are phasing out retailer licenses. So they will never give a new license, and they will never allow the transfer of an existing license. They will only renew existing licenses. So as business owners retire or pass on or move, those licenses will disappear forever, and eventually there will be no sales there. And there's one town in New York that has done that as well. And I'll talk a bit. There's one other city in county in the U.S. that's done something quite remarkable. I'll talk about that in a moment. And then just last week, Tiburon City in California became the 3rd place to ban all tobacco sales. It was a unanimous decision. Now it's on their consent calendar for November. So it's still possible that it could be stopped, but since it was unanimous, it's highly unlikely it'll be taken out of the consent decision and it will pass. And this is a big one for us because after Manhattan Beach and Beverly Hills did it, there were many other cities in California that were considering it, and then COVID hit. And it was all hands on deck for public health, and the momentum was lost. So this is going to bring that back. There are 3 other cities in Marin County alone who have this on their docket for discussion in the next few weeks. So we're hoping that this can be the restart of that process. I'm going to go back one slide because I wanted to mention something. Massachusetts is a remarkable campaign. It is being done by about 12 volunteers, 2 of which are high school students, that are driving around to boards of health meetings around the state almost every evening of the week. And this is because, except for Truth, all of the big national tobacco control organizations have not yet adopted endgame as part of their strategy. And in fact, the state coalition had a vote last year about whether to support endgame in the state, and they voted no. So the state coalition is not showing up at these boards of health meetings, but these volunteers are doing so. And they have no funding whatsoever. They're paying for their own gas. And it's an amazing thing to see that getting 18 towns to do something unprecedented in the world, most of which is in the last 15 months, is pretty amazing to see. And then globally, we have a lot of movement coming up. The red pins are places where we already have endgame laws in place. There's the pins in the United States that I already talked about. The country of the Maldives, just in June, implemented their nicotine-free generation law. So it's the sales ban with the grandfather clause. Bataan City in the Philippines was the first one to pass it. It hasn't come into effect yet because of litigation, but at least it's on the books. Then the blue pins are countries that have set endgame goals. And these are goals where they're aiming for a certain small percentage of tobacco use by a particular date. You'll notice there's a pin in the US. And we had a 5% by 2030 goal until 3 years ago when they realized they weren't going to make it, and so they changed the goal. Now it's 6.2%, but there's still no plan at the national level. California has its own goal. They want to get to 2% by 2035, and the way things are going, they might actually achieve that. And then the 2 big yellow pins are, the smaller yellow pins are places that have this tobacco-free generation goal, the goal to pass this birth date-based phase-out. The 2 big pins are places where it's actually in process. In the United Kingdom, the House of Commons has already passed their tobacco-free generation bill. It's in the House of Lords right now. The King has already endorsed it publicly. Advocates there are sure that it will pass by the end of this year. That will, in terms of the number of people who live in a place with an endgame law, that will raise that number by 50-fold because of the population of Great Britain. And then the state of South Australia is the same. Their upper house of parliament has already passed it, and advocates there say the lower house will pass it by the end of this year. Just a couple of the headlines we got from it. I'll talk about why this is important in a minute. And then in Europe, 3 years ago, they passed, they launched a program called Beat Cancer. And they want to drastically reduce the incidence of cancer by 2040 in the European Union. As part of that, they established a task force to look at what they would have to do about tobacco in order to meet that goal. And my boss was on, who's Spanish and lives in Spain, was on that committee. And after 2 years of work, they put out their report. And their report, and it was unanimous amongst the group, that the only way they could achieve that cancer plan is by doing endgame with tobacco. And so we just learned this in June, that the European Union is putting serious money behind helping individual member states of the European Union do endgame goals. And in fact, a week from Saturday, I'm flying to Athens, Greece, where the first meeting of those ministries of health is going to happen, to talk about how they go from here to getting endgame laws in place. And then most importantly, for me at least at the global level, is the tobacco treaty. How many people are aware there is a tobacco treaty? Okay, that's good, a few hands. That's actually how I got my start. When I was still in law school, I went to Geneva to help negotiate the tobacco treaty. It's called the Framework Convention on Tobacco Control. That treaty, from its inception, had an article, Article 2.1, that called on countries to go beyond the minimum measures in the treaty. And we latched onto that a few years ago as the endgame article, because it basically gives countries permission to do more. And at the last Congress of the Parties last year, they voted to establish an expert group to go look at what they call forward-looking measures. And that group's report came out a few weeks ago, and it includes 16 endgame measures in it. The next COP is coming up next month in November in Geneva, and that report will be looked at by the Congress of the Parties, which are the countries that have ratified the treaty, and hopefully adopted, and hopefully this will become the new norm for tobacco policy around the world. I should note that there are 183 parties to the FCTC. We are not one of them. We did sign it, but it has never gone to the Senate for ratification. So another thing that's been a big change in the way we think about this. When we started doing endgame, there were maybe 2 or 3 journal articles a year talking about endgame, and they were all theoretical. Last year, there were more like 600. It's become a big part of tobacco policy research. There's an entire research group at the University of Queensland in Australia that has 38 researchers working full-time just on endgame matters. So some of the opportunities and challenges. When asked, the public is way ahead of us on this. It's wildly popular. The CDC do a massive annual adult survey every year, and 2 years ago they included a couple of questions on endgame. And they asked, one of the questions was, would you like to see tobacco sales banned tomorrow? 57.2% said yes. And this is without any kind of advocacy or education. This came out of the blue for these people. When they were asked if they should be phased out, it was more like 70%. So people are way ahead. The problem is they don't know it's possible. And it's because tobacco is so ingrained in our society that it's like saying you're going to ban milk or something, right? It's part of the background. So what we need is media. And I always give this plea to people when I talk to them about this. If you do talk to someone in the media about endgame, make sure they understand that it is about banning sales, not smoking. Fully 2/3 of the articles that do come out about endgame measures, it's like clickbait. They say such and such city to ban smoking. No one is talking about banning smoking. At least we're not going to support that. We also now finally have several proof of concept examples. These things are in place, and some of them have been in place for years. And we're starting to get some of the data back showing that even though it's in a small city with cities all around it that still sell tobacco, there's a dramatic decrease in prevalence in those places that have done endgame. But again, we still have very little media attention on it, and we need to get more of that. And hopefully, when the United Kingdom passes it, that will be big enough to get global news. And then, as I said before, endgame has now been normalized in tobacco policy in most places in the world. But there, as I said, there's still in the United States several national organizations that are not on board. They're not showing up and fighting it, by the way. They're not coming to city council meetings and saying we shouldn't do endgame. They're just not showing up and saying we should. And one of the reasons we've had 5 states that had bills for endgame, and they've all been defeated largely because if you're a legislator and you're used to doing tobacco and health policy stuff, and somebody comes with you with a new bill, and you have to tell them, yeah, but the Heart Association, the Lung Association, Cancer, they're not supporting this. What are you going to think? You're going to think this can't be right. Obviously, I depend on them for my information about public health. And of course, truth can't lobby. So their support is very appreciated, but they're not the ones that can show up and talk to legislators except for education. And then just about finished, I want to talk about tobacco product waste, because one of the endgame things that we're thinking about is getting rid of cigarette filters. Almost no one smokes unfiltered cigarettes. And we have to think that a lot of people would quit, and very few youth would take up cigarettes if the filter was gone. So we've been participating in the UN Plastics Pollution Treaty for the last 3 years, trying to get filters included as a plastic to be banned. That process is not going great because it is an environmental treaty process, and there's a lot of countries that are pushing back against it, including our own. But it did raise awareness, and last year, the county of Santa Cruz, California, passed a law to ban cigarette filters, and that will come into effect January 1st of 2027. There are also a number of other California communities and some European countries that are considering doing the same thing. Some have already banned e-cigarettes because of the plastic and battery environmental problems. And there's the second to last slide. A lot of resources available out there. The one-stop shop is at ASH, but we can connect you to all the others. But there's now reams of materials out there, including advocacy materials, if you're interested. And of course, you can always contact me, and I'd be happy to talk to anyone, anytime about Endgame, as you can probably tell. So I'll stop there, and I guess we'll take questions after both of us. Okay, great. Thank you very much.
Thank you for that wonderful talk, Chris. That was great. So our next speaker is going to be Megan Diaz. Dr. Diaz is a research managing director at the Schroeder Institute at Truth Initiative. She has co-authored research on the prevention and reduction of illicit tobacco and the health effects of raising tobacco taxes, alcohol and sugar sweetened beverage excise taxes. In addition, she has provided analytic work to support defending tobacco control and alcohol tax policies in the international and state tribunals and provides technical expertise to the WHO. She has a PhD and master's in economics from the University of Illinois, Chicago. Megan.
Well, let me start out by saying thank you so much for having me. I think it's interesting that they paired me behind Chris because he's talking about Endgame, and I'm going to talk about how the industry is fighting Endgame left and right, and they're not going to go down easily. Quick slide, my disclosures. I'm going to present a lot of data from Nielsen. Nielsen doesn't like saying it's theirs. It's my work alone. Okay, let's put the tobacco retail landscape into perspective. Again, this is Nielsen data, it's retail sales data. So I just want to show the gigantic size of the tobacco market. In 2023, they made a little under $82 billion in sales. About 70% of that, that's the green line, is come from cigarettes. For all of these products, about 30% of them are flavored to taste like menthol. Two growing markets are the smokeless tobacco market, which is the orange block, and the e-cigarette market, which is the light purple block. We hear a lot from the industry that they're in the business of tobacco harm reduction, but when I see a graph like this, all I see is that they're in the business of tobacco harm addition, right? Nothing is changing. The lion's share of sales is still cigarettes, which I'm actually not going to talk about today. I'm going to talk about how they're innovating in the smokeless and e-cigarette market. Oh, I went back. Okay, let's talk about the oral nicotine pouch product market and smokeless market. Right now, it's about 12% of the market. This market had been really stable. The orange lines are your traditional smokeless tobacco products, such as Grizzly, Copenhagen. There was stuff like snus and chewing tobacco. This market had really not changed in decades. But then in the summer of 2019, Zyn went nationwide with a product called, well, Swedish Match introduced Zyn. They introduced it back in 2016, but in 2019, it went nationwide, and it just blew up. So the purple lines you see now, that's the oral nicotine pouch product market. So the growth in this market is really driven by oral nicotine pouch products. They now make up about 37% of the market, and my data is actually a little bit old. It's about a year old. If I were to push that out, it's probably closer to 45% of the market now. Again, this market had been very stable till oral nicotine pouch products were introduced. I now want you to see how they've grown. So if I break down this market by the top 10 products in the market, Back in December of 2021, Zyn was the fourth product. That's the little fourth line in blue. And I just want you to see how it grows and how rapidly it grows. Number 3 in the market were Copenhagen, Grizzly, and Skoal. These are what I call legacy products that had just been stable for decades, not really changing. So a year later, Zyn becomes the same size as Skoal in terms of sales dollars. A year after that, it surpasses Skoal. And I don't even have December 2024 data. All I have is 11 months later. It is now the #1 seller of all smokeless tobacco products. If I were to push this bar up for November 2025 data, that should come out, I mean, we're not in November, but almost in November, that bar would be substantially higher than Copenhagen. So again, this market is mostly driven by the growth of Zyn sales. Right now, they're the market leader with about 68% market share. They're followed by On with about 20% market share. Rogue, it's an independent-owned brand at 9%. Velo has 4%, and the rest of the market has about 1%. On is really competing against Zyn. Margins are really big on these products, so On is competing on prices. I suspect Zyn is gonna drop their prices, which is gonna create more demand, and On is just gonna continue to push on the price variable. On is about half the price of Zyn right now, and they're just gonna continue to push on that to get market share. Okay, so a question we get a lot is what type of nicotine is in nicotine pouches? And the answer is all types of nicotine. So some brands are made from tobacco-derived nicotine. What this means is that they take the nicotine from the tobacco plant, right? The tobacco plant produces nicotine at very high levels, and so they're able to extract the nicotine from the tobacco plant, and they're made from tobacco-derived nicotine. However, other brands are made from synthetic nicotine. What this means is that it's made in a lab, right? So it's the same tobacco that is derived from the plant, but it's lab created. It looks exactly the same chemically. However, in the United States, it doesn't matter where the tobacco comes from. Nicotine pouches are regulated as tobacco products. So it doesn't matter if they made the tobacco in the lab or if it was derived from a plant. Let's talk a little bit about flavors. Nicotine pouches come in a ton of different flavors. Mint is the most popular flavor, but they also come in fruit flavors, coffee flavors, cinnamon flavors, ambiguous concept flavors, tobacco flavors. And like I said, mint is the most popular flavor. Right now, it has about 61% market share. And 6 milligrams is the most popular strength of nicotine. They also have about 60% market share. All right, so let's talk a little bit about marketing for these products. We see oral nicotine pouch products marketed all over the place, but your standard marketing applies, right? Outside of gas stations, on products, and then the famous power wall. I think I've walked into a couple of 7-Elevens and they actually have Zyns next to the computer, so it's not even in the power wall. It is right next to it. It suspiciously does look like candy. It's bright and colorful. There's also a lot of event marketing. Zyn has been at a lot of festivals as of late. They also have a rewards program, which is a very popular rewards program. Actually, recently, you could spend 30,000 points to go see a comedian. It was a VIP event that happened recently. It was, I think, in the last couple weeks. And then, of course, their competitors also have rewards programs. I think one of our guests talked about culture and how people talk about these products. I always know a product is going to be popular when it's penetrated young culture. We've seen a huge rise of the mention of Zyn on TikTok. We've seen a rise in memes, such as this one, a ton of alluding to your lifestyle. This is one of my least favorites. It's pretty gross, and for the uninitiated, I apologize. This is a meme of how you can integrate Zyn into your life. Not a meme, it's a video. This is a Zynachino, where users put a nicotine pouch into their coffee and run it through the machine so you can have caffeine and Zyn. I don't know how effective this actually is for introducing nicotine into your body, but it's a lifestyle choice, and it's one of the most watched videos on TikTok, actually. And then there's a rise in, kind of like our previous guest said, the introduction of words into Urban Dictionary and like. And what is most remarkable is you've penetrated the market when you have copycats. And that is what we've seen. This market is continuously evolving, and we just continue to see more and more and more products enter the market. There's also a handful of products that are celebrity endorsed, such as Alp, Tyson's, and Rodman products. So if this feels really familiar, it is because we've actually been here before. Remember the proliferation of disposable e-cigarettes? Feels exactly the same, doesn't it? Which leads me into, let's talk about the e-cigarette market. So the e-cigarette market is growing, but it looks like it's shrinking next to the smokeless market. It is currently about 7%. It used to be about 10% of the nicotine market. It's not shrinking, it's just the smokeless market is growing so much that it looks like it's getting smaller, but it's not, it's pretty stable. What we've seen in the e-cigarette market is that technology continues to evolve. So I'll take you down memory lane for e-cigarettes for a minute. So they were introduced in about 2006. They were patented in 2004. When they were first introduced, we had two types of e-cigarettes. We had a reusable product and a disposable product. And the disposable product really meant to entice you to try a new product, and then you would commit to paying a lot more money and getting the reusable product. And all of these products looked like cigarettes. They were meant to be a companion to cigarettes. Then in 2010, mods and tanks were introduced. These were marketed towards hobbyists who wanted to control how much clouds they could do. They could control the heat. But all of these were still made with freebase nicotine. Juul changed that in 2015 when they introduced nicotine salts, which made nicotine a lot stronger. But also you lost the vaping clouds that the mods and tanks produced because you need a lot less strength to be able to do that. But it made nicotine a lot more palatable and easy for youth to partake in. In 2018, we saw the introduction of a new type of disposable that mimicked Juul, but it was no longer meant to be as a companion to introduce you to a product to buy a more expensive product. It was really just meant to be its own product. And now we have a new generation of disposables that don't even look like any of their predecessors. And then the latest phase of disposable products, which is what we call smart vapes. I love this quote from an executive that says, "We are becoming a tech company." Yeah, they're no longer selling just cigarettes. They are becoming a technological company. So let's talk a little bit about the evolution of these disposables. So the first evolution was disposables became disposable rechargeables. So these disposables are so big that you can't use all the e-liquid in one battery charge, but they're disposable, so they don't come with, you can't recharge it. So instead, you get a cable that you can buy, and then you can recharge it one time, and then finish up the e-liquid. But then it's disposable. You're not meant to reuse it anymore. You're not meant to buy any more cartridges. These products also straddle a lot of legislation, right? Like if there was ever a disposable ban, you could argue these are not disposables, they're rechargeables. If there was ever a rechargeable ban, well, they're disposables, right? So they really straddle regulations. We first noticed them in Schroeder Institute in March of 2021, and now they're about 20% of all the products. These products are also evolving because now they're including smart features, which include digital screens. You can adjust the flavor and the nicotine level in your product. You can access apps. Some of these are apps that are e-cigarette dependent. Some of them will sync with your phone. You get visual notifications, so you're never far away from your vape. It can tell you what your battery level is. Even though these are disposable, right? It still tells you you've only got 50% battery left to finish your product. There's proximity notifications. Again, in case you're walking out of the room and you may have forgotten your vape, you can go back and get it. It will tell you you're far away from it. There's games. And then there's a whole new generation of products. You can answer your phone now from your vape. You can get the time. It's a fitness tracker in case you want to track your steps while you vape. A selfie mode in case you want to take pictures as you vape. And now there's an AI-powered vape, and they're only getting smarter and more discreet and slicker. This is a new generation. Disposable e-cigarettes continue to get bigger. We first published a study in 2002 that documented that they were 5.7 milliliters in each of these products. If I extend this research out to the data that I have, they're now 9.5 milliliters of e-liquid in them. But again, that's an average. We've seen the introduction of what I call the extra large group. This product has 20 milliliters of e-liquid, which I'm gonna do some Joule math. Joule math is not real math. Just wanna make that very clear. Joule math is also a little tenuous. So Joule back in the day claimed that one of their pods was the equivalent of 1 pack of cigarettes. I don't know how good that math is. Consumption of nicotine depends on each individual. So, but using Joule math, which is again, not real math, this is about 26.7 Joule pods. And again, if you believe their math, this is about 27 packs of cigarettes in one product. Oh, I went the wrong way. Another product, 26 milliliters, this is about 35 Joule pods. So again, if you believe their math, 35 packs of cigarettes, 28 milliliters. And then we have the extra large group. These are the biggest ones we've seen, but they have 40 milliliters of e-liquid. Again, if you believe the Joule math, it's a little bit under 3 cartons of cigarettes in one product. People were very surprised about this. We get some charms, I love it. Disposable e-cigarette nicotine strength has also increased. It's averaging about 5%. I stood at a conference years ago and I said, I don't really think they're gonna get stronger. I'll stand here today. I don't think they're gonna get any stronger. But I will preface that by saying changes in technology could make them stronger. We know from the Joule documents that they tested nicotine strength on a lot of their employees, a great place to work at. And their employees threw up because the nicotine strength was so strong. So I don't think nicotine is gonna get a lot stronger, but I've been known to be wrong a lot. So changes in technology could actually make it more palatable and even stronger. Oop, I keep on going the wrong way, I'm so sorry. The struggle's real. But we do see products that have about 6% nicotine strength, and most of these are made from synthetic nicotine. Again, that's the nicotine that's made in a lab. And then we see these products where you can actually change the nicotine level as you use them. So, maybe you want something strong to start out your day. Maybe sometimes later you want something less strong, but the user has a lot more control over this. I would argue that this would be a tool for cessation, but I'm the only one that's marketing them that way. The industry is definitely not marketing them that way, even though the technology exists where you could maybe use these to taper down, though that's not the objective. The objective is to continue to use and taper up. And then e-cigarettes have gotten a lot cheaper. Back in 2017, 1 milliliter of e-liquid was around $9.32. Now it's about $1.64. That is about an 82% decrease in price. I like to put this in perspective. I'm an economist at heart. I am not aware of any other product on the market that has had an 82% decrease in price. We've seen decreases in computers. We've seen decreases in the prices of air conditioners, but nothing has fallen 82% in 6 years. No, 17, that's 8 years. It doesn't matter, 6 or 8 years, nothing has fallen 82% decrease in price. I wish my student loans experienced something like this. I wish my grocery bill experienced something like this. I wish my rent bill was something like this, but no, it's only for e-cigarettes that have experienced this sudden decrease in price. And again, this is an average. Averages get pulled up by large numbers. I can go online, I can find a product like this, it's $5.99. I did the math, that's 30 cents per milliliter. It's incredibly cheap. Disposable e-cigarettes may also be getting sweeter. There's one research paper out there. They tested 73 e-cigarettes. They tested some of the ones that have been authorized by the FDA. I would like to preface that the ones they tested authorized by the FDA do not contain neotane. The rest of them do contain neotane. So the 57 that they tested that do have neotane are not authorized by the FDA. If you don't know what neotane is, because I didn't know till this study came out, neotane is it's similar to table sugar, except it's 7,000 to 13,000 times sweeter than table sugar, which is hard for my head to grasp. But the mean nicotine content in these vapes was 4.6 times larger than mint candy, to kind of give you an idea of how sweet these products are, which I think just makes them a lot more palatable. Oh, I keep on going the wrong way. I'm so sorry. Okay, and just like their counterparts of oral nicotine pouch products, we've seen an increase in celebrity-owned or endorsed brands. So this graph is out of date. Officially, Juul was authorized, so this number, the 73% includes Juul, the 86% does not. So even though we've had a number of authorizations in the market, most of the products on the market, about 73% of all sales dollars for these products are for illegal products. And then we've seen the rise in a lot of dual use, right? So dual cannabis and nicotine devices. Here's another instance where I was wrong. I stood at a conference and I said, I don't think you can combine cannabis and nicotine. And I had relied on my chemistry experience. And I was like, they have different viscosities. You can't mix them. And I'm wrong. You can't mix them. They're not in the same tank, but they are in the same product itself. So you can go in between THC and nicotine. And then I'm going to end this with just, I haven't even talked about all the other products that are out there. These are just the things that are growing. I haven't talked about the menthol non-menthols. I haven't talked about the nicotine non-nicotines. I haven't talked about nicotine analogs. This is just a market that continues to evolve and evolve and evolve. Again, because they're afraid of policies like the ones that Chris talked about. They're afraid of endgame. They want to continue to make money, and they're going to be here for the long run unless we do something for them. So I'm going to finish off with some more egregious products than the ones I already showed you. This is a eco-friendly e-cigarette because you can recharge it using the sun. You know, don't worry about the plastic or any of the other stuff inside that's not eco-friendly, but you can recharge this one in the sun. This one learns your habits. It has AI in it. It can track your nicotine intake, your puff count, and it will suggest how to change the wattage, which changes the heat. When you change the heat, what you're effectively changing is your nicotine absorption. Products that burn harder will provide hotter, provide more nicotine to you. Products that burn less hot provide less nicotine. So this one actually adapts to your habits and provides recommendations. Again, this is the dual nicotine and cannabis product. You can use them both at the same time. Geek Bar, which is the most popular amongst youth, now has a THC product and a ton of other THC gummies that they're coming out with. This is a pod-based where it's a disposable, but only part of it is disposable. So you have the power bank, which is the white part, and then the pinkish red part, that's a disposable part, but that's a flavor. So you can actually have a couple of those in your pocket and you can switch between flavors. You can do, strawberry lemonade and just continue to switch throughout the day. We've also seen an increase in Delta 8 vapes. Happy to talk to anybody of you if you don't know what Delta 8 is. It's THC's second cousin. And then we also see that the top disposable e-cigarette brand has also launched a new oral nicotine pouch product. And their marketing is concurrent. It's not meant to be used individually. You're meant to use them to combine flavors together. So a couple key takeaways. Nicotine use is deepening and evolving. I think a lot of these products, like I said, are not really meant to harm reduce. I think they're intended to harm increase. You can use multiple products at the same time. Culture and marketing channels are shifting, right? We saw a big rise in TikTok marketing. There's no evidence that Swedish Match or Philip Morris has paid for any influencers, but that doesn't mean they don't benefit from free marketing that they get on these platforms. Oral nicotine pouches, within as a market leader, are a new and rapidly growing product category. I just showed you how much that market expanded. Disposable e-cigarettes are getting bigger, stronger, cheaper, and some are getting smarter and sweeter. That is a mouthful to say, but I do like saying that. And multiple celebrities own or endorse e-cigarette brands and use. And I'm here for questions. Can we sit over there? Did I scare you? I'm sorry, I didn't mean to. Okay, yes. Blair, right, I think? I can't read from there. I'm just, yeah.
Thank you both. Am I loud? I'm sorry. My question is for Chris. When you were talking, I was thinking about there was a Baltimore Sun article maybe like 2 days ago that Baltimore City is considering a zoning bill to limit the number of tobacco shops in the city. And I was thinking, like, how cool would it be if we could instead say, why don't you just stop having new tobacco shops come into the city? But I can see how that would garner a lot of objections. So my question to you is, how do you overcome objections to that particular policy?
That's a good question. First, I missed that article, and that's great. Retailer reduction is always a good idea, and study after study has shown that it's quite impactful. In terms of overcoming, I think the biggest problem, not just with phase outs of retail licenses, but Endgame in general, is overcoming this idea that it's government overreach, or that it's going too far. I think what we need to make not just governments but the public understand is that no other corporation or industry gets to do this. If anyone tried to put a product on the market tomorrow that was both highly addictive and killed when used as intended, not only would that, and we realize it right away, like this was a slow, it took us 70 years to figure all this out. If we knew it right away, not only would that product be taken off the shelves, the people that put it there would be put in prison. And there's a good example of that. About 10 years ago, a peanut butter manufacturer in Georgia realized, well, the factory people realized that there was a chance that one of their batches had been infected with salmonella. And they went to the CEO and they said, we got to recall that batch because it's dangerous. And he rolled the dice and decided, no, you're not sure it's in there, so we're going to let it roll. And 9 people died. That CEO is in prison for murder right now. The tobacco industry does this every day. Every single day they wake up and put something on the market that it's not even a chance. They know it's going to kill people. So one of the things we've been trying to do at ASH for a long time as part of our endgame goal is to criminally prosecute tobacco industry executives for manslaughter. And what we need is a brave prosecutor. If anybody knows somebody, please let me know. We've talked to several AGs. There's some interest. What we need is that prosecutor who is ambitious, that wants to someday be AG or maybe even governor, and they want that big case that's going to get their name known. This isn't crazy. We have had law professors come and spend 2 days in a closed room with us, tearing apart our brief on this, and they've come away saying this could work. It just hasn't been done yet. But once it's done, if you make it a criminal charge to sell tobacco, the next day, obviously you can't sell tobacco in that jurisdiction anymore. So please, if you know a prosecutor, we're looking.
Good morning, thank you. Eric Turner, Prince George's County. So I noticed on the for product placement rules, tobacco has to be in a certain distance from the cash register. And I noticed when taking site visits with my tobacco enforcement officer that Zen is getting closer and closer to the counter. So I can wonder if you can comment on that.
Well, supposedly as part of their authorization by the FDA, they have extra rules that they're not supposed to do that. To my knowledge, they're not really following any of the rules. I don't really have anything else to add, but yeah, that is also what we've seen. And they're just blatantly breaking the rules. But Reynolds and Philip Morris, I know it's Reynolds, I'm not sure if it's Philip Morris, flat out came out last month and said that they're not even going to bother submitting PMTA applications for a couple new products because the FDA hasn't moved. So they have no problem just blatantly ignoring the law. I know, that very uplifting this morning. I'm sorry.
Chris Bloom, Anne Arundel County. I have a question for Chris. When you talked about local legislation, I think you mentioned that when legislators go to look at bills trying to be passed, that maybe the American Heart Association or Lung Association or Cancer Society aren't supporting those legislative bills. Can you talk a little bit more about that?
Sure. So like I said, they haven't been showing up and coming out against them. But I can give a good example. In August, I went up to Boston to testify at a hearing on a statewide nicotine-free generation bill. And on the docket were about 8 other tobacco control bills. And I don't want to get anybody in trouble, but one of the big 4 voluntaries, or the big 3 voluntaries, or CTFK, were there, and they got up and they testified on the other tobacco control bills, but they did not mention nicotine-free generation. And that kind of killed the bill, because legislators have a lot of things to worry about. They have to become experts on everything overnight to make good decisions, and most of them do. They want to do what's right for their public, and so they rely on experts to tell them what they ought to be doing. And most legislators that are interested in public health or tobacco control are used to relying on heart, cancer, and lung, because they've done the research. They're the experts to tell them what would be good and what wouldn't be good. And when they're silent, if you're unsure as a legislator, it's easier to do nothing than to do something that might be considered radical. I have no doubt that they will eventually come around. And this has happened before. Ash is lucky. We're small, and we can take risks. And it's happened several times in the past where we've come forward with an idea. A good example is trade. About 10 years ago, there were a slew of cases run by the tobacco industry using trade law to stomp on countries' tobacco control, very aggressive tobacco control policies. And so we decided, well, why don't we go and see if we can get carve-outs in these trade agreements to protect government's right to do tobacco policy. And it took me 6 years, and we did it. We got it in the Trans-Pacific Partnership Agreement, and then that language actually has now gone into other trade treaties. But at first, no one else would help us. But it took me 2 years, but I did convince them. And once those voluntaries came on board, then we got it, because they're the ones that have the 501c4s, the lobbyists on the Hill. They know the senators. That was the reason. We would have never gotten it without them. So I have no doubt they'll come along here too. It's just they're a big ship, and it takes it. We're speedboat. They don't turn very fast.
Oh, okay. Oh, hi. So, when I think of the younger generation, like Gen Z, they seem to be a very activist kind of generation, especially like climate change, gun violence in schools. Can you speak to, are youth interested in maybe an activist kind of agenda against tobacco use? I just feel like I remember like truth was like super common in my generation. So I kind of am curious, are they thinking of that through an activist lens of fighting these guys?
Yeah, I can start with that. I think at Truth, one of our biggest challenges is that we have a generation of youth that actively rejects cigarette smoking. I think that first speaker that talked about language also mentioned this, that they would never say that they're, cigarette smokers. That's our big challenge right now, is it's a generation that actively rejects smoking, but has fully embraced other forms of nicotine because they're candified. So rates have come down for youth. There's no denying that there's been success there. But those that are using on more days and more frequently. And so that's, I think, one of the hardest things for us. I think another big thing that's hard for us is the dual generation is now having kids, and they actively, fully embrace these products as well. And so it's hard when they're having kids to reject nicotine when their parents are actively using nicotine too. Very depressing. I'm going to stop talking. I'll hand it over to Chris.
I'm going to be a bit more upbeat. I mentioned in Massachusetts that of those 12 volunteers, 2 of them are high school students, and I've been completely blown away by what they've been able to do. They've actually started a podcast, and they interview experts every week, and they just started broadcasting it last week. Tiburon, the city that just passed the complete ban on sales last week, that came about because a local youth group came to the city council earlier and said, we could do this and we want to do it. And they got it on the docket, and then they showed up in force during the hearing and testified, basically saying, we're the generation that's going to have to deal with this. We're the ones you're taking away nicotine from, and that's what we want. We want it to be gone. I also want to point out that if we can't get kids on the health or the nicotine or the tobacco angle, environmentalism and they are showing up. Santa Cruz County, that filter ban was not even led by a public health group. It was led by a local youth environmental group. Manhattan Beach, California, the second city to ban all tobacco sales, that was led by the surf riders. It wasn't even led by a public health group. So we've been really happy to work with environmental groups, especially around this plastics pollution treaty. It took a little convincing because they don't live and breathe this like we do. They thought filters actually filtered something and help and make the cigarette less dangerous. But once they understood, they have come on board, and they're carrying most of the water for us. So I think that's the next evolution in advocacy. We've got to bring the environmental aspects into it.
Yeah, I will add one extra point there. The environmental aspect has also been very successful at Truth. Like, kids actually care a lot about that. And then for us, the mental health angle as well. So amplifying the message that nicotine does not help your mental health, it actually makes it worse. We received a lot of slack when we first put those messages out, but those came from messages from youth themselves that wanted to see the connection to mental health. And so that's also been a good talking point for us, that that was youth-led, that using nicotine doesn't help your mental health as you think it does. It actually makes the problems worse.
Mike. Oh. Okay. So we've been looking at some data in the AHR primarily, trying to see if there's any correlation with heart disease, with major adverse cardiac events, so MACEs. And so far with e-cigarettes, we're not seeing a direct correlation yet. When they're dual users and they smoke and vape, then we're seeing it, but not with vapes alone. So I guess my question to you would be, are you anticipating seeing this when these people mature, or are we never going to see these?
I think I have the qualifications to fully answer that, unfortunately. I mean, I think my biggest concerns is young brains on nicotine. I do think e-cigarettes and oral nicotine pouches are a reduced risk product for adults using cigarettes that fully transition. I don't think they help youth in any way. I worry about young brains on nicotine. That is my biggest worry, at least from a short-term perspective. But I'm really not qualified to answer the long-term issue there.
I'll just add that you're asking an economist and a lawyer. So there's many people in this room way more qualified. Okay.
Oh, yes. Yeah. We make a good team.
Oh, yeah. Hey, lawyers are great at making stuff up.
Did you guys have a question for each other? Okay. In that case, thank you for a wonderful session. We appreciate your. So we're going to break for lunch now from 12 to 1:15. Lunch is in the cafe, and as you walk out, you will be directed towards the cafe. And after that, in the afternoon, we have a breakout session. So one session will be here in the auditorium, and the second session will be in room 307. Again, when you come back from lunch, just come back to the registration desk and we'll point you in the right direction. And enjoy your lunch. Thank you all for your attention. I also want to thank my team, Colleen, Julia, Carissa, and Michael. Thank you.
Hello, everyone. Welcome back from lunch. Hope you enjoyed it. We're going to get started with our breakout session. I'm introducing Dr. Janaki Deepak, my wonderful boss. She is a pulmonologist, and she has won multiple teaching awards as well as the Joan Stein Award. Dr. Deepak works in the lung mass clinic. She directs it at the VA, and she is also the director of the Nicotine Health Clinic at University of Maryland. Dr. Deepak is a wonderful champion of tobacco treatment, and I think we're all really excited for her talk. Dr. Deepak?
Thank you so much. I'm not going to be able to move. I've been told I cannot move because this thing will not be heard very well. Clearly, I paid Julia to say all these nice things about me, but thank you, Julia. Having said all that, I'm excited to be talking about cytosine because it's helped me evolve and learn more about this. And this is the molecule of cytosine. And there's also corporate greed I'm going to talk about here on something that is potentially a cheaper alternative, but already made a little bit more expensive. Okay, I have no disclosures. Not true. I'm extremely passionate about tobacco treatment. I did not call it stopping. I do not call it quitting. I don't say cessation. And I apologize if that's not with the norms. Okay, I want to try to tell you how this works, right? So cytosine and cytisinicline, I'm learning how to pronunciate it, I'm sorry. If I'm too loud, let me know because I've got a very loud and carrying voice and I don't need anyone to get hearing loss from my loud decibels. Gonna kind of summarize the evidence on what is the evidence right now comparing cytosine to NRT and varenicline, some of the adverse effects, dosing regimens, and a little bit about the special populations it's been potentially studied in. Again, this is a new drug, not yet in our market, has an NDA in, and but we need to learn about it. So if you will take a moment and take a screenshot of this QR code and kind of answer those questions, if you don't mind. Trying to keep this interactive. And y'all can come and sit in front. I promise you, I won't say anything. I won't ask you anything other than this one QR code. Let me know if everyone's done with the QR code. Yeah? Okay? Okay, done. Perfect. So those were the questions. So answer it as we are going through. Don't cheat. Answer it potentially now before I go through the specific slides. So currently 6 FDA approved medications because the 7th one, the nicotine inhaler, was conveniently discontinued because they couldn't find the resin mouthpiece for it. Like, you know, what an excuse, right? Resin mouthpiece not available, discontinued nicotine inhaler. Varenicline has been proven time and again to be the most effective medication. It's expensive if it's not covered by insurance, and nausea and nighttime dreams, which can also happen, those weird vivid dreams can also happen with nicotine replacement therapy, and that can limit the uptake of the medication, but I will say the biggest thing is cost. And we would like to have more medications, and there's been no new medication since 2006. So it's high time we have a new medication. So very busy table. I don't expect you to read the table. I'm sorry about the busy stuff in here. Just telling you what has been studied so far. So in terms of pharmacotherapy, nicotine replacement study, 133 trials with 65,000 participants. The risk reduction is 1.55, high certainty studies, and the forms that have been studied are patch, lozenge, gum, inhaler, and you can see how well the inhaler did compared to everyone else. The nasal spray, which again requires a lot of prior authorization, not really available. And the mouth spray, which is not available in the US, but available in a lot of the European countries. And you can see that the mouth spray and the inhaler did really well compared to patch. Other pharmacotherapies, look at Varniclin. It is really, really done well, and there's high certainty, multiple trials on this. Bupropion sustained release also has done well, very high certainty. In terms of combination pharmacotherapies, short and long-acting NRT is about 1.25. Varniclin with NRT is 1.62, kind of mimicking patch alone with Varniclin. And again, the problem is when they say NRT, they are not always talking about reliever medication. The way you approach tobacco, as I've said in multiple different slides, is you do controller and reliever medications. Your controllers currently are the Varniclin, bupropion, and the patch, and your reliever medications currently available are the gum lozenge through Quitline and nasal spray only through prescription. And then behavioral therapy with pharmacotherapy is 1.15. Combined behavioral with pharmacotherapy versus brief advice, you can see that the combination of behavioral and pharmacotherapy, and I'm talking about behavioral therapy, which is not brief advice, is also been really proven. So that's where our landscape is currently, and we are going to see what's new on the market and how can we get on it. So cytosine is a plant-derived alkaloid from Cytisus laburnum. It is a partial agonist of the alpha-4 beta-2 nicotinic acetylcholine receptor. Just to say, it works in nicotine acetylcholine receptors in the ventral tegmental area. It competes with nicotine in those binding sites, and Achieve Life Sciences for marketing in our US trials decided to call it cytisinicline. I think they were trying to mimic varenicline, and so they decided to call it cytisinicline. I am going to refer to it as cytisine, just so that I can pronounce it, if you don't mind, Okay, so that's where the corporate greed comes in, just so that you know. It's a partial agonism. It produces 40 to 60% of the nicotine receptor activation. It provides moderate dopaminergic response, and thus it reduces withdrawal, right? Like we know that the pleasure hormone is dopaminergic, and that dopaminergic stimulation helps with reducing the nicotine withdrawal. And so you get reduced craving, you kind of get like a reinforcement, but it is not as high as when you're smoking or vaping. It blocks the nicotine's full reward, so it's a functional antagonism, if that makes sense. And it's got a short half-life, that is cytosine, and it requires frequent dosing. So if you look at cytosine, cytisinicline, and varenicline, they all of them are alpha-4 beta-2 partial agonists. Cytosine has 4 hours of a half-life. Cytisinicline is 6 to 8. Varenicline is 24 hours. The metabolism is minimally hepatic in cytosine and cytisinicline, and in varenicline, it's renal. The course length duration is about 3.5 weeks for cytosine, about 25 days, and for cytisinicline, it's about 6 to 12 weeks, so slightly higher. Varenicline is 12 weeks, but there are many studies which have shown 24 weeks, 6 months, which is 6 months, and even up to 12 months. So there are studies going beyond the traditional 12 weeks. Cost of cytosine, as it stands today, less than $30 US. Cytisinicline, because Achieve Life Sciences decided to make the synthetic compound, it's $100 to $200. And of course, we know varenicline, if you don't have insurance coverage, is very, very expensive. So in terms of cost differential, it's better than varenicline, but we would so like it to be closer to cytosine. So what is the evidence base? So this is one of early randomized controlled trials by West and New England of Medicine in 2011. It was a double-blind randomized controlled trial of 740 smokers done in Poland. The intervention was cytosine, 25-day course, and brief counseling. And the comparator was placebo and counseling. The primary outcome was 12 months of continuous abstinence. And what they found was that cytosine performed better than placebo and counseling alone. And the GI symptoms were about 10% in cytosine, but there were no serious adverse events. So that was good. So basically what they said was cytosine tripled the long-term quit rates versus placebo. But again, the long-term quit rate was 12 months. Now, cytosine versus, oh my God, it's not nicotine. I'm so sorry. Nicotine replacement therapy, guys. Sorry about that slide. I didn't catch that. I apologize. So cytosine versus nicotine replacement therapy for smoking cessation, trial done in New Zealand by Walker and group. 1,310 adult daily smokers with a 25-day course of cytosine, 8 weeks of NRT, and both the groups had low intensity telephone behavioral support. Okay, so both the groups had that. Primary outcome was self-reported continuous abstinence at 1 month. Secondary outcome was abstinence at later time points and adverse events. So you can see in this table here, and I don't know if it's, oh, it's working. Perfect. And you can see that how cytosine in days between quit and relapse rate, right? You can see that cytosine was at about 200 in terms of probability of continuous abstinence, was much better at cytosine than at nicotine replacement therapy. Was I still heard, Colleen? Yeah, okay. I told you I'm really loud. Okay, so cytosine clearly demonstrated superior effectiveness over NRT for continuous smoking cessation, and 40% of the cytosine recipients versus 31% in NRT. It persisted at 1 week, 2 months, 6 months. The median relapse time, and this is what I found good, was that the median relapse time to relapse was 53 days for cytosine versus 11 days for NRT. And adverse events were a little bit more common with cytosine, and primarily it was nausea, vomiting, and sleep disorders. They were mild and moderate. They were not serious side effects. And the number needed to treat to prove that cytosine was superior was 11. So that's not a bad number at all. So that's pretty darn good. So this was again in 2014. Okay, then this is the ORCA-2 trial published in JAMA in 2023. This is a randomized trial which had 3 arms. It was done in about 800 or so people, but finally they had 442 women and 368 men, adult who smoked 10 or more cigarettes and had an expired air carbon monoxide concentration greater than 10 parts per million. And unfortunately, they decided that being ready to quit was a criteria. I wish they had not done that in ORCA-2 and ORCA-3. I wish it was modified better. The mean age of the participants was 52.5. And as I said, it was about 810 participants randomized, 618 actually completed the trial. So how it was done, it was cytosine for cytisinicline, not cytisine in this, cytisinicline for 6 weeks, 12 weeks versus placebo for 12 weeks, okay? And all of them had behavioral support. Again, so it is cytisinicline at 6 weeks, 12 weeks, and placebo for 12 weeks with behavioral support. The primary outcome of this was biochemically confirmed continuous smoking abstinence for at least 4 weeks of the 6-week and the 12-week treatment. And as you can see, cytisinicline for 6 weeks versus placebo, odds ratio of 8. Cytisinicline for 12 weeks is odds ratio of 6.3. Julia, time? How much? Okay, good. I just want to make sure I'm on track. Sorry. I should have it all here, but I don't. Cytisinicline so ORCA-3, right? So now it is cytisinicline again for 6 weeks, 12 weeks versus placebo, mean age of 52. Here it says adult smoking greater than 10, but if you actually look at it, it was a pack a day for at least 36 years. So 36 pack year history of smoking. Mean age was about 53, more closer to 53, and they were ready to quit in this group also. This was 20 clinical sites, previous was 17 clinical sites, and again, biochemically confirmed. And what they found was the smoking abstinence at 12 weeks with cytisinicline was 30.3 versus 9.4 in placebo, and 14.8 at 6 weeks versus 6% in placebo. So again, I did not know why they did not include NRT or other proven therapies here, right? So now let's look at the main thing, right? So let us look at cytisine versus varenicline, because we said varenicline has been proven to be better. So this was again a JAMA trial. This was done in 2021. The question is cytisine non-inferior to varenicline, okay? And it did not demonstrate the non-inferiority, unfortunately. You can see that in this, the cytisine, it was 11.7% versus varenicline was 13.3%. So again, varenicline showed that it's not superior, but it's really good at doing what it's supposed to do, that is help people stop smoking, verified by a carbon monoxide breath test at the 7-month follow-up. And non-inferiority was set at 5%, which you can see cytisine did not meet here. And this was done in Australia. Younger population, as you can see, younger population. So this is another study which was done in primary care in Croatia and Slovenia, randomized controlled trial, 377 participants, cytosine, this is cytosine, in 25 days versus varenicline, 12 weeks of treatment. Primary endpoint was abstinence from smoking at 24 weeks, biochemically verified. Varenicline was 32.46, cytosine was 23%, and basically, again, compared to varenicline, cytisine did not do as well. In terms of adherence, however, cytosine was better compared to varenicline, and this was mainly thought to be because of the GI adverse effects, and the cytosine had fewer adverse effects. Okay. Now, meta-analysis, there is a Cochrane, there's the Addiction and Network 2024 meta-analysis. The comparators are placebo, NRT, and varenicline. And varenicline, as you know, it's kind of comparable efficacy, is a little bit a stretch here, but it was not too bad. It did do better in adherence, and it did do better with side effects. For NRT, it is superior to NRT, and definitely significant benefit from placebo, which is considered, according to me, cold turkey. So how do you dose this? You dose this drug. Cytosine is standard 25 days, and it has a very complex regimen, as you can see. Cytisinicline, the ORCA protocol, is more like 3 milligrams 3 times a day for 6 weeks, and then you can go on to 12 weeks. That is much more easy And basically they say set quit date, which I don't do, but you can do it if you want. And it's a synthetic formulation. And again, it's a 25-day taper. I don't know what is the magic of 25 days. They have not explained it anywhere. Okay, so is it tolerated? So again, it's nausea is slightly lesser than Varnaclin. Sleep disturbance is better than Varnaclin. GI upset is about the same, whether you're comparing it to placebo and NRT. Headache is the same, and no serious adverse events. So discontinuation for adverse events, less than 5% in our trials. If they discontinued it, it's a nausea, nausea, nausea. And there was no real cardiovascular or neuropsychiatric signal. Remember, there's no neuropsychiatric signal from Varnaclin. We removed the black box warning in 2016 because of the Eagles trial. Do not forget that. Don't keep harping about neuropsychiatric signals with Varnaclin and bupropion. It doesn't exist. And the contraindications are mainly hypersensitivity to cytosine and caution and severe renal impairment. So what about the special populations? So they're stable, the pharmacokinetic stability in different groups, except for renal impairment. Patients with psychiatric comorbidities, no problem. No hemodynamic changes with cardiac disease. Pregnancy, there's insufficient data. COPD asthma, it actually improved quit success compared to placebo and secondary analysis, tolerated in older adults, and there's no human RCTs of cytosine in pregnancy, though animal data does not produce any teratogenicity at therapeutic doses. WHO and ACOG say that NRT is preferred for pregnant patients. Cytosine is not contraindicated, but there's insufficient data. Breastfeeding, limited excretion, but still avoid unless necessary. And because of its low CNS penetration, it has reduced lightheadedness and confusions in elders. So what about our global access? So Eastern Europe, it's been there over the counter for so many years. Eastern Europe, in the essential medication list has not been centrally approved, but country level sales have been permitted. UK licensed it in 2019 and launched it in 2024 as prescription only. WHO decided to add it to the essential medication list. It's recognized as an effective, low cost, and globally scalable cessation or treatment. And enables international procurements by low middle income countries. And it's the first edition of a new pharmacotherapy since 2006. In terms of USA right now, the status in FDA, I don't know what is happening, but FDA accepted NDA for cytisinicline in September 2025. The target date is June 20th, 2026. The trade name is cytisinicline. It's going to be an aid to smoking cessation in adults, and they have to have a pharmacovigilance plan in place. So we have to have behavioral support, right? You have to have motivational interviewing. We need to engage, focus the patients, start having them think about the problem and plan how to do the problem, and use many models for this, including telehealth models. And it is also being approved in 2026 potentially for treating vaping disorder, because that's what we have found. People who vape now cannot get off the nicotine. So they need treatment. So it's been approved. There are studies already for Varnaclin in vaping, but cytosine, they are working to expand it to vaping cessation. So I hope I've told you about cytosine and cytisinicline. They are effective, they're safe, potentially more affordable first-line therapies. They're comparable to Varnaclin, superior to NRT, and have excellent tolerability. And we have increasing global recognition of this. And here are your post questions. I think you all should be able to answer this. I mean, it's the same QR code as the first one, so you don't really need it. It's the same questions. So, oh, it's a different QR code. Sorry. Everyone has to do QR code. I'm so sorry. I apologize. Or not. That's fine too. If you're not interested, I'm perfectly fine. I'm a little competitive, so I do all these. Okay, done? Okay, moving on. So the answer is that it's a partial agonist, right? And the most frequent adverse effects are GI and sleep disturbance a little bit. Standard regimen length is about 25 days. And let's not forget our Maryland Quit Line. They offer it via phone, web, referral, text, every possible way. And it is an awesome resource. This is our nicotine health clinic. That whole thing doesn't belong to us. We are one small office on the 9th floor, but we do everything thanks to the very generous grant support from the uh, Department of Tobacco Prevention and Control. Thanks to David Quinn. Sarah Wolf, who gave me the first entry into this in 2019, she heard me talk and she said, you know, do this. You can actually do it. And thanks for making and believing in us and helping us do this service. We have about 1,100 patients in our seen in our clinic now in inner city Baltimore. And feel free to email us, find Julia, call us. We're happy to see patients. The Maryland Tobacco Resource Center, and you've seen these slides many times. And we are part of the team with Dr. Khanna's, and we also collaborate with them. And that's it. Thank you.
Not really a question, but a comment. First, thank you. I've been thinking about cytosine for years. I've actually met Vitold and Christoph in Warsaw, the ones that worked on this in the beginning, but I never learned about it until now. So that now I understand it. Thank you. But the comment is in September also, cytosine was added to the WHO list of essential medicines,
Yes.
which is going to give permission for dozens of countries
Yes.
to go ahead and allow it to be,
Yeah.
to be used there.
Yeah, I had that in one of my slides. I'm sorry. Yeah. Yeah, no worries, no worries. I had it in my slide on how they included it in the EMA so that everyone could get it. And that's what I said, cytosine, if we get it like the European product, right, it's cheap. Unfortunately, we now change it to cytisinicline, and it's the synthetic compound with Achieve Life Sciences is going to be slightly bit more expensive, which doesn't help my inner city population really afford those medications. And right now, with all the restrictions, it's kind of tough.
So I was going to ask, why are they using I forgot how to pronounce it, but what's the benefit of not using the actual plant and using the medication?
So I think it's got to do with how it's delivered to the brain and how it actually works. Because if you just use the plant, you do not get the same kind of effectiveness as you're using but cytosine is as close as it gets to plant-based. And the minute you make anything synthetic, right? So yeah. Here.
Thank you so much for telling us about a potential additional tool for our toolbox. My question is just thinking about what we currently have, and of course, many states are losing, many resources and funding for even just the 1-800-QUIT-NOW line. Is there any risk or concern that that's going to happen in Maryland?
That question should be directed to the top of the room there, David Quinn. Yes, he can answer that question. Yeah, I'm so happy you asked that question.
Yeah, thank you. Funding is always a concern, but right now we're in a position where we can fully maintain all our quitline services. We have all of our specialty protocols, behavioral health, pregnancy, even menthol. That's up to 12 weeks of the NRT benefits still available. And we plan to monitor our situation and kind of provide the services as best we can to all Maryland residents. But for now, we are still up and running. So.
Can we give a huge applause to thank you. Thank you.
Thank you, Janaki, for your work. I appreciate it over the years. I really do appreciate the call out. Thank you.
Thank you.
That's it.
Thank you all so much.
Tobacco use and exposure. She serves as the chief of the Division of Hospital Medicine at Children's National Hospital and professor of pediatrics at the George Washington University School of Medicine and Health Sciences. She is the immediate past chair of the American Academy of Pediatrics section on nicotine and tobacco prevention and treatment, and is on the board of directors for the Campaign for Tobacco-Free Kids. Dr. Wally practices clinically as a pediatric hospitalist and is a certified tobacco treatment specialist. Thank you, Dr. Wally.
Thank you, Julia. And I am just going to use the mic, but tell me if it's too loud or not loud enough. Thank you guys so much. And thank you, Dr. Khanna, for this invitation. I'm relatively new to the DMV area. I've lived here for 4 years. And so I just appreciate what passion you guys bring to the children and adults, families in this area when we're thinking about prevention and treatment for tobacco and nicotine dependence. So I'm a pediatrician, as you heard, and I got into this field as a pediatric hospitalist. So I focus only in the inpatient setting when children are admitted to the hospital. And, I started noticing kind of a sort of funny thing that, a lot more children, anecdotally, which of course is borne out by the research, that had parents that smoked would be admitted for respiratory things like asthma and something called bronchiolitis, which really just affects infants, and pneumonia. And started learning, of course, in medical school, you learn tobacco is bad and you need to tell your patients to stop. But, that's really kind of where it ended. And so that was part of where my journey into learning more about it. And then, as everybody here knows, in the mid, 2010s, vaping and e-cigarette use really became an epidemic among youth. And so, although thankfully, based on a lot of the work that you guys have done, we've seen a decrease in cigarette use by youth. We have seen, as everyone, again knows, that, vaping and then now some of these oral nicotine pouches that Dr. Diaz spoke to you guys earlier about have, been such a problem among our youth. And so I am excited today to talk about the new American Thoracic Society guidelines for treatment of nicotine and tobacco dependence. And I'm going to also, as we get into our learning objectives, be talking about the American Academy of Pediatrics guidelines and show you really a cool web-based application. Maybe just to start by show of hands, who here is in public health? I mean, everybody here is in public health, but maybe not seeing patients would be a good way of putting it. Okay. And how about people who maybe see patient or see students or see clients that you would be in a position to talk about tobacco dependence and prevention? Okay. So a pretty good number as well. And I think this talk is definitely relevant for everybody. Just as we heard about a new, potential pharmacotherapy, these are all things that we as a community should be aware of and can be advocating for. So today, over the next 40 minutes or so, and probably less, because I would love to have some, question and answer period, as well as we've got some show and tell. I know, again, Dr. Diaz talked about a lot of these vaping devices, but I think there's nothing like actually seeing them, particularly in the context of the case presentation that we have. We'll talk about the American Thoracic Society, I may say ATS, slip up, the clinical practice guidelines, which just came out a few months ago to address youth nicotine dependence. And then we're also going to review the American Academy of Pediatrics ACT model. I guess thinking about disclosures, which I did leave out my disclosure side, I was involved in both the American Thoracic Society and the American Academy of Pediatrics ACT model in terms of the creation of those, but I certainly got no money for either of them, so it's not a financial disclosure. And then I am on the board of directors for the Campaign for Tobacco-Free Kids, also a volunteer activity. And then the only other thing that I did want everyone to know, and we'll talk about this, is that unfortunately, there is not pharmacotherapy that is FDA approved for under 18 years of age. Now, that being said, as a clinician, as a physician, we oftentimes treat people, and in this case, children, outside of the FDA if you feel the benefits outweigh the risks. But of course, I do just want to let you know that. All right, let's get started. So this is going to be really fun talking about bringing you into the hospital where I work at Children's National in DC. So asthma is one of the most common diagnoses still, even though we have such great medications to prevent and decrease the symptoms. But this is a very typical. I actually was working last night. I was telling people I got home at like 2 a.m., so a little bit later. But this is really the time right now with the seasons changing, but admitted a 15-year-old for an asthma attack. This patient was diagnosed with asthma a little bit later in life at 4 years ago, but in the past year, her symptoms and her attacks have really worsened. So this is actually her third admission for asthma in the past 12 months. So that's a really big deal. Even one admission for asthma is kind of felt to be like failed outpatient therapy, but this is her third. And so a confidential HEADS assessment, which is a screening tool. Have anyone here heard of it? Okay, good. And I'll go through it in a second. But the patient does deny alcohol or illegal drug use, but does admit to vaping nicotine, denies other forms of tobacco nicotine when you specifically ask about oral nicotine products or pouches, and then combusted tobacco. So what is a HEADS assessment? And I think, helpful to just know what pediatricians should be doing consistently. Like if you have a teenager and go into, the pediatrician office, we know that right now healthcare oftentimes is just about seeing people quickly. But this would be what the standard for screening is for adolescents. And so the HEADS assessment is pretty simple. It stands for home, education, employment, eating, activities, drugs, and I mean, that's a big area, includes alcohol, tobacco, and illicit drugs, sexuality, suicide, depression, and then safety. So you go through that. We typically will do that, or it should be done without the parent, and then we'll document that confidentially in an inpatient confidential note, because in the adolescent community, when you're talking about an adolescent, parents generally can view their medical record unless you put that specific designation on the document. All right, so you continue to ask, and this patient vapes flavored, disposable Elf bar, and here's where I'm going to be pulling out some stuff and letting you guys see. And she says she does that multiple times a day. And I didn't put in here, but she uses like an OMG blow pop. And then she's been vaping for the past 12 months. And who remembers when she started having these asthma attacks? Well, she was diagnosed with asthma 4 years ago, but then it really got bad about a year ago, exactly. And so, as we know happens a lot of times, adolescents, they start using because, of social interactions and oftentimes a lot of the flavors. And then because, as again, Dr. Diaz explained, it's a really high level of nicotine, and adolescents get addicted much faster than adults because of their immature brains. So now she's finding herself needing it all day. Now, this exact example, to be honest, most of the time when you show this level of dependence, and we'll get into that, there's probably going to be some co-use with maybe oral nicotine pouches or other tobacco products, but just for sake of being a little simpler, I'm just saying that she's vaping. And she used to be a great soccer player, but she had to quit because she really can't do it anymore. All right, so again, they're going around so many products. I think all of you guys heard from, how many times am I going to say Dr. Diaz? But heard from Dr. Diaz today just about how technologically advanced some of these products are. And the bag that's going around, if people want to pull stuff out, there are some of those smart vapes that include like the digital vapes that, have gamification. And they also, like the more you vape, the higher sort of scores that you'll win on the vapes. So it's really important to ask your patients about which vape, and then, that way, I mean, oftentimes I'll just get on the internet and find out like what the nicotine concentration is. And that way, in terms of treatment, you'll have a better idea. But we already asked, or I already asked about where kind of people are practicing. And so when not you, Dr. Khanna, but when people encounter patients similar to this, what is the usual response? Like, what are the options that you have? We heard from David Quinn that the quit line's not going away. So that's great. And I do have refer to primary care provider, but I know I have gotten feedback that people will say, well, I went to my pediatrician and they said they weren't sure what to do. And so that makes me very sad. Anyone have a idea of something maybe in Maryland? Because, again, I'm relatively new and may not be aware of all the resources. That's pretty much it, right? Okay, so that's where you guys come in. You guys are going to be the ones to tell your patients and even potentially be able to tell their primary care provider about some of these new guidelines. So as I mentioned, and this is free access, the American Thoracic Society has a new clinical practice guidelines that we're going to go over the major recommendations. And they do include pharmacotherapy. Obviously, for sake of time, we're not going to go through every detail of it, but just hitting some of the highlights. But before we do that, I really do want to take you through a current resource with the American Academy of Pediatrics. And there is a wonderful, we're going to, Colleen, I know maybe that bar, which I know has been bothering us, we can move. Okay, perfect. So this is great. A screenshot of, or actually this is the actual live, and we are going to access the tobacco cessation app right now, just so people know whether you're a clinician or not a clinician about this resource. And so Colleen is going to hit access the tool for me. And then it's really pretty simple. And so the American Academy of Pediatrics ACT model is act, counsel, and treat. And so it does take people through what the American Academy of Pediatrics recommendations for counseling and treatment for adolescent patients are. Now, we are in a time frame with the American Thoracic Society's recommendations just coming out that I'll just let you know a little bit of a difference, but I still think is super relevant. So let's go ahead and use our case study to go through this. So let's say yes, the patient uses tobacco, and we'll say that the patient is interested in a quit attempt. And then what this does is it helps you determine the level of dependency. So let's just go ahead, Colleen, and just say like the highest level for each of those. And so it says, I find myself reaching for an e-cigarette without thinking about it. Almost always. I drop everything to get out and get e-cigarettes or e-juice. Almost always. I vape more before going into a situation where vaping is not allowed. Almost always. And then when I haven't been able to vape for a few hours, the craving gets intolerable. So now this says the patient has a severe dependency. It calculates it all for you. Now at the very top, Colleen, if you can scroll back up, sorry, you can actually just set, maybe if you set it, go ahead and set it because it'll erase all your other stuff, but you can select an option and you can just say they're severely dependent. So I do think that there is a world where, you can actually have the adolescent do this themselves. So they're like, oh my goodness, like this is saying that I'm severely dependent. And then you go to next. And I think the great thing about it is it does kind of help you with what, again, the American Academy of Pediatrics recommends as first-line treatment, which is nicotine replacement therapy. And so it will recommend behavioral support as well as nicotine replacement therapy, and then keep going down. And it kind of gives you instructions about how to use, a nicotine patch for long acting, and then the nicotine gum or lozenge for the short acting. And then keep going, Colleen. Next, yeah. And then I think actually this is really helpful too, because it tells, you guys probably know some of these, but your patients and your families probably don't know any of these. And they're just in a very easy, digestible, user-friendly way to look at it. So just press next. And then of course, follow-up is extremely important. And I believe that's the last one, Colleen, if we can just scroll all the way down just to be sure. And then left-hand side, there are resources, which I think is also really helpful. There's the Hooked on Nicotine checklist, which you'll actually see a little bit later, which is another way of looking at dependency. And then there's some validated other screening tools. So this is just a place for you guys to share with, providers, know yourself. And then I think it is for the right type of adolescent. It is a resource. All right, thanks for going through that with me. All right, so back to our slides. So we already went through a lot of this, so I'm just gonna kind of breeze through. And then oh, okay, sorry. I'm asking a lot of Colleen, so thank you. Okay, so we just went through this tobacco cessation. Now, I will admit that saying that it's an app is a little bit misleading because there's not an actual app. It's a web-based application app. But that is, it was sponsored or funded by the CDC. And so you can imagine where that funding has gone at this point. But I do think that it will continue online and then have other iterations. Okay, so this is another way to look at it with the flow chart of basically, the ask, counsel, and treat. And so the ask, we kind of talked about that, the screening part of it. And so this will actually give people language. Do you use any tobacco or vaping products like cigarettes, e-cigarettes, or dip? I do think with the fast evolution of the oral nicotine pouches and the fact that, rural white men still are certainly using quite a bit of dip. But in general, I think urban youth or, many of the youth in Maryland, we may see are using the oral nicotine pouches. So again, we're not going to go through this specifically, but I think good to know that this is a resource, again, on the American Academy of Pediatrics website. So, when you're thinking about asking, you want to use that standard objective language. And then another screening tool is the CRAFT, and what I would say is the 2.1 plus N. And the reason is that it does include that HONKed, which is the hooked on nicotine screening. And this looks at dependence, like how dependent is that adolescent? And what you see now is specific to vaping, which has also been validated. And so I'm just going to read off one of these questions. Do you vape or use nicotine now because it is really hard to quit? There are sort of a variety of 10 questions, basically. And I think the really interesting thing is that even if one of these is positive, so that's what I tell people when I'm training, just try to remember like one or two of the questions. And even if one is positive, that's viewed as, likely that this adolescent is, has dependence to nicotine. But you can see that with this study, that even just one has a 32% probability, but easily when you go to two positive questions, that's 64%. So again, just remembering, do you vape or use tobacco now because it's really hard to quit? Do you feel addicted? I typically will try to say, have you ever felt like number 5, have you felt like you really needed to vape or use tobacco? But everyone has a question that they feel like really speaks to their patient population. All right, and then continuing and just finishing up with the American Academy of Pediatrics model, when you look at counseling, that is really counseling patients, about quitting tobacco. And, of course, with adolescents, you need to use relevant and kind of age-appropriate short-term goals, which might include, things like, hey, do you know that, adolescents who use tobacco and nicotine are going to have, brown teeth or not perform as well in sports or have more acne? Some of those things are what really speaks to them versus saying something like, you're going to develop cancer in 30 years. Because oftentimes that is not going to be as really engaging of a topic or interesting as a topic to them. And then I typically will jump to, are you interested in quitting? As I'm an inpatient provider, which I've already talked about, it oftentimes isn't really that big of a stretch for me to say, you're here in the hospital with an asthma attack. We know that vaping is a contributor to that. And, as your doctor, I would love to, talk to you about things that, might help you not have to be admitted again. And of course, using your motivational interviewing and saying like, would that be okay with you? And of course, they're going to say, yeah, I don't want to be admitted again. And then that's when you would talk about your counseling and your recommendations. And then if you're interested in quitting. And then the treat part, we already addressed a little bit the American Academy of Pediatrics recommendation for pharmacotherapy in moderate to severe dependence is nicotine replacement therapy. And I'll talk about that just briefly. Part of the rationale was that at the time that those practice guidelines were developed, there was not the same level of evidence that you'll hear about with the American Thoracic Society. And the rationale was that these are over-the-counter medications. And of course, that can be purchased by 18 years and over, that don't provide a drug that is different from what they are already getting, i.e. nicotine. And so that was a rationale for including NRT, nicotine replacement therapy, in the American Academy of Pediatrics guidelines. But one of the things that is, of course, extremely important is particularly for adolescents, and that is overall the guideline for behavioral support. And that can take many different forms, whether that's, with the provider, with, a group, through school, or through their, through other, youth organizations. But I do recognize that that can be hard to find and hard for those adolescents to keep up with. I've been trying to get my 16-year-old to go to SAT prep, and that's been hard enough. So definitely know that with these teenagers, oftentimes the reliability and the continuity is one of our biggest challenges. And so again, this includes some of the other resources that you guys know about, the text to quit, teen.smokefree.gov, which I will just say that I don't have a lot of teenagers that really love that program, but I think every teenager is a little bit different. All right, and we've already talked about the level of tobacco dependency, low, moderate, or severe, and that the American Academy of Pediatrics, when there's a moderate to severe level of dependency, based on either that hooked on nicotine checklist that I showed, or, again, make it easy on yourself and just go through the steps on the web application app, and it can lead you to what that child's or what that adolescent young person's dependency is. And then, here we're just kind of repeating what I've already said with behavioral support and pharmacotherapy. All right, so now we're gonna get to the American Thoracic Society and how it's different and how it's similar to the American Academy of Pediatrics. But this is treatment of nicotine use in adolescents under 18, because the FDA's current six forms of pharmacotherapy that have been approved are approved from 18 years and older. So that leaves a big gap for the over 10-12% of adolescents who are current users of tobacco products right now. All right, so this is specifically targeted to adolescents 10 to 18, and it's also specifically nicotine and tobacco agnostic. And so what that means is, whether they're using, they're vaping, they're smoking cigarettes, which we know is, really only about, 2 to 3, 4% of adolescents. The recommendations we're saying are the same. Now, all that to say, most of the evidence oftentimes was with cigarette smoking. And that contributes to the level of evidence, but we wanted to make sure that we had guidelines that were relevant and helpful for clinicians with what we are currently seeing now with youth use. And so there are 5 main recommendations, and I'm just going to go through those 5, and then we'll go back to our case study. But the first one is sort of a no-brainer. Actually, this is the one that I was focused on. And maybe just to give a little background, we had a large group of experts in many different fields, public health, pediatrics, certainly, with significant expertise in tobacco cessation. And we spoke as a large group And then we broke into smaller groups specific to some of the specific recommendations. And then we looked at the evidence and then wrote that up. But for recommendation 1, for adolescents 10 to 18 who use nicotine and/or tobacco products, we recommend a counseling-based nicotine use intervention. And this was a strong recommendation. And I would say that this fits with all, pretty much all the recommendations from major medical groups that we see. Recommendation 2 is that for adolescents 10 to 18 years of age who use nicotine and tobacco, we suggest a technology-based nicotine use intervention. And so one of the studies that is discussed in the practice guidelines, which actually came out too late for us to put in our data analysis, but we felt was very compelling and helped us with this recommendation, was the Truth Initiative and Amanda Graham's study, randomized control trial, using the text to quit in younger age groups. And that did show a benefit of that technology-based intervention. And so I would say, this is another, with moderate evidence, a strong recommendation. Recommendation 3, which I would say maybe is the most controversial, if you will, but for adolescents 10 to 18 who use nicotine or tobacco products, no recommendation can be made for or against nicotine replacement therapy. And basically that was a lack of consensus. Between that larger group, we did not have enough people who voted to have a recommendation in either way. And so just to point out that this is different than what the American Academy of Pediatrics recommendation was. And just to point out that the ATS, American Thoracic Society, the rationale for this was not based on side effects of nicotine replacement therapy. It was really just based on lack of evidence for efficacy. Recommendation 4 is that for adolescents 10 to 18 who use nicotine or tobacco, we suggest a trial of varenicline. And this is probably one of maybe the most forward thinking. Again, there was a study that came out after the data analysis was performed that also showed efficacy of varenicline. We've already heard about the efficacy of varenicline in adults, but formerly this had not been a recommendation in the adolescent age group. And then the last recommendation is around bupropion, which is also known by the trade name Wellbutrin, is also used for depression and anxiety. So for adolescents 10 to 18 years of age who use nicotine and/or tobacco products, we suggest a trial of bupropion. I would say this one is a little bit less novel in that many adolescent providers who have adolescent patients who already were, who had comorbidities of depression and anxiety would often use bupropion, knowing that there would potentially be the effect of, hoping with tobacco cessation, for their patients who use tobacco, as well as anxiety or depression. So those are the major recommendations. What's similar is, the behavioral-based counseling, technology-based interventions. The differing part is on the pharmacotherapy. And as we've kind of talked about, the American Academy of Pediatrics does recommend nicotine replacement therapy for moderate to severe dependence. And the American Thoracic Society, as you just saw, their recommendations are for a trial of varenicline or bupropion. Obviously, thinking about the risks and benefits for that individual patient, because as of now, it's not FDA approved. However, our hope, being on the ATS, this, group, this expert group, is that oftentimes when the American Thoracic Society does come out with clinical practice guidelines, that there will be potentially, and I don't know right now with everything going on, but there will potentially be a relook because, insurance companies, of course, and and Medicaid, including Medicaid, they are going to pay attention. Right now, if you were to prescribe varenicline or bupropion, oftentimes it would require a prior authorization that would need significant paperwork by the provider in order to get approved, in order for the patient not to have to pay out of pocket. So let's get back to our case, our 15-year-old who, is getting the other therapy that is needed while they're in the hospital for an asthma attack. And she is interested in quitting. You're able to talk with her parents out of the room, which, for some adolescents is totally easy because their parents like drop them off and then pick them up and you don't see them again. And then other parents are like literally hovering over their bed the entire time. So just think about if you have teenagers, which one you would be. And that is not saying that either one is better or worse. But we want to talk to our adolescents by themselves because oftentimes they don't want to share the same information as if, their caretaker or their mother or father are standing right there. But this patient says she's interested in quitting. And as we saw, the level of dependency is severe. And so we would recommend, based on the American Academy of Pediatrics, the application and the web-based app, that we would do nicotine replacement therapy, as we already went through. And then the behavioral support that we talked about. The American Academy of Pediatrics, I didn't really get into this, but when we talk about nicotine replacement therapy, it's not, all sizes fit all. With severe dependency and the amount that she was vaping all through the day, we want to provide her with the long acting, which is the patch, the nicotine patch, and then a short acting for cravings, which is either the gum or the lozenge. However, if we're looking at the new American Thoracic Society recommendations, that would again recommend behavioral cessation support. So the same text to quit, the limited resources that we already have with the 1-800-QUIT-NOW line, and then pharmacologic treatment, which would be varenicline or bupropion, a trial. And so that is something that I think right now we're in a period where, providers continue to need to, kind of make that individualized decision. So I will just say, myself as a hospitalist, who generally and hopefully does not see a patient more than once because they come into the hospital and then hopefully, we have provided them, what we call wraparound care where they can go back to their pediatrician and then continue with some of the preventive medications. And so in my practice, I typically would not start varenicline or bupropion because that would need to be followed. There are definitely situations where I'll call up the pediatrician, and my husband's an outpatient pediatrician for full disclosure, and say, I would really recommend this patient really needs a lot of support. Would you consider prescribing varenicline or bupropion? And here's how to do it. I would love to hear what other people in the audience, particularly for some of the clinicians, what they have done with adolescents. I don't know if adolescents go to your clinic.
So yes, no, I have one here. Thank you. So yes, we've seen adolescents, and of course that was before ATS came up with its guidelines, right? So we have done, I knew this was in the works because I was in the Tobacco Action Committee. So there's been so much discussion on this. But right now, since we have the new guidelines and it's published, I would do varenicline. I do need to kind of understand the pharmacokinetics a little bit better in this age group, and is it different from other age groups, and to see how long I can do it and how do I tweak it. But we have done nicotine replacement therapy, and we actually had, I think, one patient on nicotine inhaler along with the nicotine patch. I know it's not in the recommendations, but that's what really helped them stop vaping, and That inhaler, of course, is gone now. So I was also wondering if you could comment on the use of nicotine nasal spray, and why is it not in American Academy of Pediatrics, or like anything else? Like, has it even been thought about?
So I think everybody heard, but the nicotine nasal spray, the nicotine nasal spray for the group that was really considering it wanted to just make sure that access was was considered. And because it requires a prescription, it was felt that we wanted to stay with the over-the-counter options, which are the nicotine patch, the nicotine gum, and the nicotine lozenge. So that was really the major reason. But you do bring up a good point. There are other forms of nicotine replacement therapy, some of which, well, the inhaler's gone, but, can sort of mimic the hand to mouth. So great comment. Anybody else want to comment or think, is that something that you might see patients or clients or providers be okay with? I do think that the cost is certainly a significant issue. I think all of us know that we're in a healthcare crisis right now. We're already, as pediatricians, struggling to get children and adolescents like the bare minimum of generic medications that we need. And so I do worry. I have not specifically written a prescription for a 15-year-old. It would definitely require a prior authorization and probably several calls to try to get that through insurance. Certainly not saying that that's not worthwhile. However, it is a barrier. So anyone? All right. Let's see, we're almost done. So we can hopefully, oh, yes, we are actually done. So who has the bags of stuff? Let me see. Okay, somebody's raising their hand. I think this would be kind of a cool exercise. We could pull out one of those vapes, and I took this out of my slides, and kind of see like how much nicotine is in this vape and how does it compare to a pack of cigarettes? Some of the products now have 20 milliliters of liquid and it's 5% nicotine. So that is like a crazy amount of nicotine, equivalent to like 50 packs of cigarettes. So that's just quick math, but others can help me in the room. Oh, did you have a question up there?
And then also, ironically, it's like, it's recyclable, so you're saying it's like trying to be environmentally friendly. So funny. I just thought that was.
That was really, it was great that you noticed that. And I think the other thing that is interesting is, of course, this generation is thankfully, very interested in the environmental impact. And so that is definitely something. And Chris, did your group do some work with this environmental impact of vaping devices? So that is definitely something that I know many groups have been talking about, but that is kind of a new one that they want to give you a friendly reminder that you need to finish something. So great point there.
For varenicline or bupropion?
So, I apologize because I don't remember the exact number of days. But typically, I would say that for either varenicline or bupropion, we heard that, you could do 12 weeks. And I think that would be
You know, to me, that doesn't, that a trial does seem a little bit, what's the word? Misleading, because it makes you kind of think, oh, I'll just try it for a week. But I think for me, and the intention is that they wanted you to utilize it like you would in an adult patient. But great question there. I mean, and I think one of the things that I always think, and of course, I'm sure all of you guys are thinking is, you know, what's the regulation on these products and why are they allowed to just say random stuff like finish this in 15 days? And, you know, there's certainly a period of, you know, you could argue completely unregulated, which is not quite accurate, but inconsistent regulation and enforcement. So, but I mean, you stop at any gas station or vape store, and there's a lot of these products that are very child friendly. So, thank you so much. I really appreciate everybody's attention.
Thank you, Susan. Thank you for some wonderful talks, and thank you to the audience for being here and the folks online. I just want to give a big round of applause to my team, Michael, Colleen, Julia, and Carissa. And I want to give a big round of applause to our MDH team who supported us all the way. Thank you all. And certainly look forward to working on tobacco prevention and control, no more control, prevention only per Chris, so tobacco prevention with all of you. So thank you all. Please do complete your evaluation. Tell us what you want to hear in the future. If you like today, make sure you tell us that, because when we know to find more speakers like this, otherwise, whatever you say, we shall try to accommodate. And thank you all.